manuia. I le lofa mane angan leo le atua. Avea ilo nei whātau waa e whai mafonga tau monmoni. O le sunga tamaitai whaatonu, ia Luisa Choir. Mai se fwoi le tamaitai fo mai a Dr. Annie fo vai mana mamalo nei ofisa. E whaatanofa, ma whaafeinoa ia tu ai. I le pa ia mana mamalo mwhai na sao mai nei aso, le aso lona lua. O le whaamoemoe le ofisa Medicaid in the Macho Summit. E whaatapu pa ia whaatafa nei maota. O pa ia wha le malo, pa ia wha le atunuu, mai se foi pa ia wha tala nei. Ia le anu atu ia wha tini o tau sala. Le ngā whatau di maina e se tau talanga a le wha tau waa. E tau nau wha pe atu, wha tai te le lava le awhiwhio mai, ma tala mai au. Ia wa mawadunga ai le wha moe moe le nei ofisa. Ai pe ona masani ai a tātou tū mā ngai whanua, e au lava ona mua mea i matau sa, sulai nei le vi inga ma le anga le leo le atua. Ia ua mawhai ona whaatau no uina, le nei wha moe moe le manuia. E au o lea, o le asau nia se talo pupu, ia e a mātari ai tātou wha moe moe. Tātou i wha matano. Le rio a uena mātou tamasi CDSA. O mātou poto i nalo i fole nei malu e whaafo i atu le vi inga o le wha manu ma le wha ane tanga i lau fio. O no avanoa e saunia e mawhai ona mafuta fia fia lau whanau. O matanga duenga ese tau te soifua mano loina. Tanga duenga le malo, company, ma pisinisi tu maoti. Ai mai se le loa le nei atu no. Ina ia whaatatan noa ina ma whaasos e winga i le tāua o le soifua malolo ina aduadu i duma o le nei atu no. Whaafitai, i le whaafawina o le malosi le nei tai au, whaafitai mana tunatunga le lei, mātou te tano i lau fio, ia mua au muri au lau fio i whaamoemoenga le nei aso, a mata ia te oe, whai umea i lau fio. Ia mawalunga pervi ingo oero mātou tua. Ai mātou te iloa, e re tai ona ato tua na mātou au aunanga, pia re au wai lau fio, whaatangisia lava lo wanganga ina ia tai tōrua mai mātou, tala na mātou whaalongo, ina ia mawhaiana ofi ngō fie foi, na whaasoa nisi o mātou uso, ina nei tu aso, mātou tano a mātou se mangsana i elofam whaamangalo. Ono lo lava sofa Yesua ma so one mala awa tuai. Amen. Ladies and gentlemen, this is the second day of our Medicaid Health Summit. And if you were here yesterday, you witnessed a great presentations regarding the benefit services here at the Medicaid office. Eligibility was also a big issue yesterday. But we also went into depth with our panelists, clinical panel, discussing ways to further push the envelope on prevention. O te tāua lava nei whaamoemoe, i oe wa tātou silafia, tūlanga lo i e tātou system, the health system here in American Samoa, ia a oa au wale mwhaen tātou ngā lue whaatasina ia fo, ia i nei whaafi tāuni. Yeah, early prevention and early detection is the theme of this year's summit. So, without further ado, I would like to introduce our Madam Director, Mrs. Louisa Choir, for her opening remarks. Ladies and gentlemen, Director of the Medicaid Office.
Thank you, Deputy. Talofa, Tayamanuia. Good morning, everyone. Welcome back to day 2 of our Medicaid Summit. It's great to see you all here as we continue this very important conversation. I also want to take a moment to thank those who helped make the summit this summit possible, our partners at ASCC for hosting us in this beautiful venue, J&E Productions for decorating the space, HB Media for our audio and visual, Kvzk for broadcasting live, Folding Table Productions for videography and promotional content, Daniel Whitcomb for photography, Local Delights, can we hear it for our caterer for taking such good care of us and the delicious meals, and our sponsors at the Pacific Center for Human Security and SPEAR via Community Cancer Coalition. We were blessed with a glorious performance by the American Samoa Choir yesterday, and we are truly, truly grateful and appreciate everyone's support. We couldn't do this without you. Our theme this year is strengthening a health-resilient American Samoa through prevention. Ne'itoi oto lopulo woto wanga. Yesterday was a really strong start for us. We began with our keynote speaker, Dr. Audrey Tarr, who challenged us to think differently about the work we do. She shared the analogy of people falling into a river and how too often our systems are focused on pulling people out instead of going upstream to understand why they're falling in to begin with. That really is the heart of prevention. She also reminded us that this work requires humility, being willing to work together, to learn from others, and to recognize that strengthening our system is not just about funding, but also about partnership, capacity, and how we approach these challenges. We also heard from our Medicaid team explaining our benefits and eligibility process, policy and planning being described by our deputy, and the work underway to improve access and strengthen how we serve our people. We then had a strong clinical panel with representation from the Department of Health, LBJ, Medassist from New Zealand, and Medicaid, all at the table, all sitting right here. What stood out was how aligned the message was. We heard about the growing burden of chronic disease, the missed opportunities to intervene earlier, and the reality that too often patients are entering the system when it's already a crisis. We also heard clearly that prevention is a shared responsibility. It takes coordination, the right incentives, and all of us working together if we're serious about creating a medical home for our patients. As we move into today, we're building on that conversation and shifting the focus beyond the clinic and into our communities, because prevention doesn't start in the hospital, it starts long before that. Today's session will include Medicaid finance, program integrity, and our partners, including the Pacific Center for Human Security, with Money Follow the Persons presenting to us. We'll also be facilitating a community panel discussion focused on prevention where people really are, in our homes, families, and community. You'll hear more about our efforts to stand up the home and community-based services here in American Samoa. So I encourage you to stay engaged with us throughout the day. It might be an early day for you, but please stay engaged. And with that, it's my pleasure to introduce our clinical director, Dr. Annie Fuavai. Dr. Annie is a retired physician who served at LBJ for more than 30 years in both OBGYN and the emergency room. She earned her medical degree in Fiji and completed her postgraduate training in OBGYN in New Zealand. She is deeply rooted in our community, a leader in many spaces, including serving as Taʻitaʻifono for the Awa Catholic Church, a member of the St. Francis School Board, and president of the champion cricket team Awa, Teine Oliseaula. She is also part of the first graduating class of Fasao High School. Most importantly, she is a proud daughter of the late Aumoe Ualongo Te'o J. Fuavai and Fatuiva Fuavai. Please join me in welcoming our clinical director for Medicaid, Dr. Annie Fuavai.
tai atu le sunga tamai tai pule mo le whaalau loa fo i o lo whaatau whaai nei tai au. Whai fo isina umi o le nā whaalau I loa. O le ale tuli loa ina whaapito au o le taua pa ia mamalu o le aso. A wale a fifio o lo o tō mamalu. A o le atau mawhai atu se tala. E tu so le wha moe moe o le ne yasu. O le soi fua ai malolo ina. O se mea alofa tā ua lea. Tātou te whai mo I tātou. Ai meise I lātou e pele ia I tātou. Ma o le mata whai oi whai whaatasi a tangata uma. O le a inga ma se atunu. O le upu maasania sa moa. Pe atuta se vaa na whai whaiva. E le lei lava le piiva. E whamanatu mai ai ai tātou. O tātou tiute ma whaiva. O le ngā lulue whaatasi. O ai e ai le pule. O ai e taita I le malo. O ai e whaia upo le atunuu. Upo le nuu. Whai whe au ma tangata lau tele. E ta tau ona ngā lulue whaatasi. Au ale soifua malolo ina o tangata uma. Ina ia aua lava ne I puea tātou I matangi angi vale. Ma toe oto atu pūlou ua tō ti munga. Pe ua tele fo I se ngā luenga e toe whai ai. Mana tua le upu ale atunu. Ele ai se whaalelei ele. E tu sa atu, e sili atu, I lo tu langa vai. O lou lava lelei, ma le malo lo ina o lo soifua, o lo o iate o I lava. E manuia lo maumanga ma lelei lau whatoanga. Pea e sa vali lava oe, e polili, whaaolaola, bele le vau, toto, ma tausi lelei. E fua mai foi, e lelei. Wa tele tangata wa mali liu talavou I le tatou watunuu. Whai I ai se tatou fuafuanga. Ma ia lo fangia lo soifua. Nei toe tō ifo lo pūlou ua tō timunga. Angia wha, sau mafuie, ma tutupu ai loa ma whaalavilavi. The theme for our summit today is strengthening health resilience through prevention, which means proactively reducing risk, building capacity, creating sustainable health systems that can withstand, adapt to, and recover from pandemics, climate change, etc. Resilience is not a passive state, but it's an active program strategy. So rather than focusing on reactive treatment of diseases, our focus should be taking preventive long-term actions to eliminate the cause of disease. Because the cornerstone of resilience is prevention. And this should drive us, not only building strong primary health care, but more importantly, whole of society approach. And that is engaging communities coordinating across government and private sectors, because these are essentials. Essentials for effective preparedness and prevention. Soifua Ma'ia Manuia Fontang.
Apatu mai spesifik boleh sungar formai ya Dr. Annie Fuafai ya manana saudara fapitoa menias. Oleh nei teimi ya tato tiri se ya tato presentations, the tato mental break near activity with Agnes Tilo Namus Tiri.
Thank you, Deputy. All right, everybody. How's everyone doing today? Okay. So we need to get that breakfast moving. I would like for everyone to please rise again from your seats. Please stand up, everybody. We're going to do a little bit of movement to get the blood flowing, get everybody stretched for today. So, our activity for today are listening for 2 words. The word is care and covered. Okay, can everybody say care? Care. Can everyone say covered? Covered. Good. When I'm going to read out a passage, and every time I say the word care, you are going to move to the left. And when I say the word covered, you're going to move to the right. Okay, let's give this a try. Care. Covered. Good. Okay, is everyone ready? Hey. The passage goes, an individual in our community begins by applying through the American Samoa Medicaid office, taking that first step towards being covered. Good. Once approved, they are officially covered. Yes. Gaining access to the services they need to support their health. Being covered means they no longer have to delay treatment or worry about how they will receive the support they deserve. It means a pathway has opened. From there, their journey continues with coordinated care. Good. Appointments are scheduled, referrals are arranged, and follow-ups are ensured so that every aspect of their care is connected. Whether receiving care locally, good, or through off-island services, each step is planned to make sure nothing is missed and no one is left behind. In the end, being covered and receiving consistent care creates a stronger, healthier community. When individuals are covered, they can seek care with confidence. And when care is coordinated, being covered becomes more than a benefit. It becomes a foundation for well-being across American Samoa. Give yourselves a round of applause, everybody. Thank you for caring. Okay. Just like yesterday, we're going to go into a roundtable conversations amongst yourselves and ask the question, what would you prioritize? Off-island referrals, provider shortages, or preventative care? So decide amongst yourselves which one is your priority and ask why. We'll give you 5 minutes to discuss, and we'll call on our volunteers, and there is an incentive to volunteers. We have a few giveaways, so please volunteer. Okay, 5 minutes, everyone. What would you prioritize? Thank you. 2 more minutes. All right, our time is up. Okay, who would like to go first? Okay, we have some volunteers. What would you prioritize and why?
Well, thank you for the opportunity. My name is Tashi Monga. We had a very thorough and intuitive discussion with our panel over here. I decided that off-island would be our priority, but the consensus with our table is preventive. Preventive, it's better to prevent than to treat. The reason we left off-island referral as the least in our priorities is that if preventive fails and our on-island providers cannot provide, then we'll go with the least priority, which is off-island referral. We agree that off-island referral is always there, but let's try and prevent our people from getting to that point, and also use our providers, maybe increase the providers to decrease the number of off-island referrals. Thank you very much.
Okay, give it up for the off-island referral priorities. Okay, this is a token of your appreciation for your participation. The whole table gets an incentive. Okay, we have one more. Oh my gosh, okay.
Let's say we have one from the balcony.
Okay. We'll hear from the balcony first, and then we'll do one from the floor.
Hi, we discussed that all 3 options are important. The offline referral, however, only covers the person that's referred. So in terms of like a systemic priority, we think, again, preventative care would help the majority of the population. And it would have to start early, looking at stores that provide packaged foods that is right in the sight of children, also working with schools and parents to kind of change the narrative of health in our community. Also for provider shortages, our table discussed how it's not sustainable to bring specialists in for short periods of time. It would be a priority to fortify our education system, to grow our providers from within, to equipping our students with the ability to complete medical school and then come back and serve our community. Both of those two options provide, it doesn't just help one person, it can help, it's unlimited how it affects our community. Thank you.
Thank you very much. That was a very good answer. We have one more for, okay, we're gonna go at the back, sorry. Everyone's participating today, I love it.
I apologize, I did not attend yesterday due to other commitment, but my name is Moli Lamana. I'm the Vice Chair of the Community Health Center Board for the Department of Public Health. Our priority is prevention. Salu's 80, I'm almost 70, and look at us. Why? It's your responsibility to take care of your own self. But we wait too late. Our emphasis now with the Board of Community Health Center to keep telling people, go to the clinics, go to the health center. Don't wait till you're sick, too sick, and run to LBJ. Hence, the traffic is congested. You take care of yourself. We prevent our own self. I'm bringing my smoothie with veggies and vegetables and fruits. You take care of yourself. You do that prevention. Don't wait, because sometimes when you wait and you complain the system is broken, the system is not broken. It's you who is breaking the system. Thank you.
Prevention care, thank you very much. Let's hear one more from the floor. Director?
Thank you. My name is Ingafo from the VA. Yeah, similar, our table was looking at preventing care is for everybody, you and me. You got to take care of yourself. You make sure that, you know, your health is good. Stay away from eating pigs and all that stuff, fat food, you know, because that's what, to me, there's a good food over here. I eat coconut in the morning instead of pea soup in the morning. So those are like a preventing care for me. And that's my point. Before you go to the, you know, the provider shortage, we all see inside, on island, we have shortage of doctors and nurses. So this is a big thing that I look at it, and I'm scared to go to the hospital, because when I go there, I sit around for how many hours, and then the Fomai comes, speak Filipino, I couldn't understand Filipino, you know, so those are the things that we gotta look at. Off island, I'm looking at people that, not that the low income. I rather use my VA benefits like TRICARE to give it to our hospital, so it can be benefit everybody on island. And that's my thing for being in the military. Everything that I trying to provide for our community, so it would benefit everybody else. And that's the same thing that I trying to give to the veterans. If you're veterans over here, you qualify for TRICARE, please. This is what we got to give it back to our community, because that's a big time money that will help our community to help to fill up all this, the preventing care, provider shortage, and off-island purpose. Thank you.
Thank you very much, and that concludes our mental break activity. We'll turn over the mic again to Deputy. Give yourselves a round of applause, everybody. Thank you.
We'll have more mental break activities throughout the day. So if your table did not get a chance to receive some of the prizes that we have up here, you still have a chance before the end of the day. But now we're going to turn it over to our first presentation of the day, and we will be focusing on Medicaid finance. O le tātou presentation leo le aso o uman tātou tana noi benefiti ma ngā vaa i le aso ana nafi sa tātou whaalongolongo fo'i I presentation tau the state plan and why Medicaid is the way it is. A o nei la le a tātou whaalongolongo I le whaatupeinga o au nanga ese o a ia limitations, o a fo'i ia guidelines, o tuina mai I le federale. Ina ia puipuia I tātou I nei, ia marwhao ngā ina o tātou se leni. Ia ato ai ma limitations I le se leni whaaloto I whale. So ladies and gentlemen, please direct your focus to our Finance Division Head, Mrs. Wilhelmina Sailuatonga Fau, who will be presenting for the Finance Division.
Good morning, Talapalava everyone, and welcome to the best portion of our summit, the finance presentation. My name is Wilhelmina Sailuatonga Fau, and I am the newly appointed Finance Division Head for Medicaid. Like Jeremiah Fale yesterday, I am only a few months old into this role. I have here with me my colleagues, Mrs. Nemo Mangel Salavea, who will also be presenting, our staff accountant. And even though our team lost a valuable member, Epifania Yosefo Solofa, we also gained a new one, Mrs. Rosamana Faivai Sitai, in the back. And we are very happy to have her. So last year, our finance division consisted of 3 members. This year, we are still a 3-member team. And just like last year, we continue to fulfill the Samoan proverb, Elaititi ai maini. Nemo, Mana, and I, between the 3 of us, manage 7 different Medicaid accounts, compile and certify quarterly federal reports, compile local reports, process reimbursements for our administrative vendors and medical providers, organize and keep records of all claims for each service, and heavily monitor our most important account, which is our local match, local subsidy, better known as the local match. Now, before we start on the finance portion, I'd like to take a quick survey of our attendance, just like last year. Do we have any local providers in attendance today? If we can get a show of hands, local providers. Current and potential if you're looking to be a provider. I see 1, 2, 3, 4, about 4, yes, thank you. That's a little less than last year, but we are very happy to have you. Any community stakeholders? You're just here to learn, listen. Quite a few, I love it. Do we have any ASG counterparts in the house? 1, a few, yes, okay. Well, I'm happy to see a good mix in the attendance today, as this information pertains to everyone. Anyway, without further ado, let's dive into today's session. All Medicaid state agencies are governed by a code of federal regulations. It's the legal framework that ensures government agencies comply with established statutes and provides transparency for the public. Medicaid is covered under CFR Title 42, Chapter 4. A Google search will yield the direct link for your reading pleasures. Every Medicaid agency is further governed by a document specific to the state or territory known as the Medicaid State Plan. This is what we call our Medicaid Bible and has all the information pertaining to our program. The first part to understanding the claiming process is understanding the presumptive eligibility concept. As mentioned yesterday by our Deputy Director, American Samoa operates under a presumptive eligibility model, and moving forward, we can call this the PE. That means that we do not do individual eligibility enrollment. Everyone is presumed eligible for local LBJ and DOH services. All services outside of these public facilities are subject to cost share requirements. Also, as mentioned by Deputy Director yesterday, the PE model was initially established for LBJ when LBJ was the sole American Samoa Medicaid provider. It has since been extended to our second provider, DOH, which are our federally qualified healthcare facilities. This means that those individuals who meet the beneficiary criteria stated in the state plan are eligible for services outside of these medical providers. So where does that leave the other half of our population? Because according to the most recent census data, about half of our population would be ineligible for Medicaid services under traditional eligibility rules. This issue led to the establishment of the Aina Care program, where a portion of our $6 million local budget has been earmarked for this population. What does this mean for Medicaid finances? Costs for the Aina Care program are claimed at 100% local. No federal dollars are allowed, unfortunately. This is not an issue that is specific to American Samoa. In fact, I recently watched an interview of California Governor Gavin Newsom, where he boasted that he is proud to be one of 16 states who offer medical care to the undocumented population in his state. These types of programmatic activities are fully funded by the state. They cannot claim federal dollars for it. And this is the exact type of program our Aina Care initiative is. It allows us to offer medical coverage to a population that pays American Samoa taxes but aren't eligible for traditional Medicaid benefits outside of LBJ and DOH. To show the disparity or the comparison between California and American Samoa Medicaid programs, our director met last week with the California Medicaid director, and I happened to mention it to our state officer, our CMS state officer, and she made a comment and she said, well, this should be an interesting conversation because California's 1% in any given fiscal year is bigger than your 10 years total of expenditures. And so we're looking forward to hearing how that conversation went, Director. Now, while our population is but a fraction of California's, their Medicaid program has revenue sources that fund their state portion, which allows them to get more creative and flexible with their programs. And this is one of our initiatives we're trying to do with the Medicaid Aina Care program. Let's get back to the PE because I digress. When the PE formula was introduced, the ineligible population was about 10% of our total population. Times have surely changed, our population demographics have changed, and the types of food we eat have changed, so our health issues have also changed as well. In turn, our programs must evolve to meet the specific needs of our people. Yesterday, Deputy also mentioned that moving to IE would be, while it would definitely benefit the finance portion in our federal claims, make it a lot easier, it would be a detriment to our community and especially our one and only LBJ hospital. This would mean that LBJ loses half of its Medicaid funding because about half of our population would be deemed ineligible and they wouldn't be able to claim them under Medicaid. This would also mean that our other programs would be affected. We would be able to cover more services in theory, but we would be able to cover less people. And our focus is always the people. One point I wanted to mention before we get into all that, 2025 Titoi Michaela Sailua was recognized for her place-based teaching style, which focused on specific traditional, cultural, and unique needs of her students. 2025 National Teacher of the Year, Ashley Crossnunn, also has a similar teaching approach, recognizing that all communities are different and require different teaching styles and approaches is what made the difference in their presentations and in their candidacies. In the West, Western culture resonates with the students. In the South, the Southern values, traditions, and cultures would resonate more than, let's say, California values. There's no one-size-fits-all teaching style, and each must adapt to their specific needs of their respective students. This approach translates perfectly to the healthcare industry. Place-based healthcare allows us to assess the specific needs of our people and build our programs around these needs. Okay, now let's get back to the PE for real. In the fourth quarter of each fiscal year, around August, our benefits division compiles what we call the PE report, utilizing data collected from the different organizations such as the Immigration Office, DOC, the Census Office, and LBJ. This data then is input into a CMS pre-approved formula that is also laid out in the state plan. And this formula determines the claiming percentages for each demographic for the next fiscal year. In September of FY25, Mr. Jeremiah Fale, our new benefits division head, compiled this report from which our current claiming percentages were derived. The PE claiming percentages this year, if you want to write them down, actually I have them on a slide later on, are for the MAP is 39.7%. Sorry, before I get into the specific percentages, so what is the FMAP? The FMAP determines the federal government's contribution to Medicaid expenditures each year. This is the key funding in American Samoa. American Samoa boasts a 83 permanent percent FMAP, which not everybody gets. Every state is different, but the territories have a permanent 83% FMAP. These FMAP changes every year. Historically, the FMAP was 55% before 2020. Since October 2019, the FMAP for American Samoa has been permanently changed to 83%. For the Children's Health Insurance Program, in moving forward, we'll call this CHIP, the enhanced FMAP sits at 85%. Let's get into providers. So how providers get paid by Medicaid. One of the main criteria for enrolling as a provider is to have a payment methodology. This is, it has to be an approved payment method, and it varies by provider and by service offered. And these services must be specific services expressly stated in the state plan. In addition to that, the patients you are serving must meet eligibility criteria also mentioned in the state plan. So the following is a list of the providers we have and their different payment methods and their local funding requirements. The hospital operates under a Certified Public Expenditures Model, which is the CPE. This means that they get federal reimbursement through Medicare, then they submit to Medicaid for our portion, and their funds are already certified as public expenditures, so they don't require a local match. The FQHC is encounter-based. They receive $150 per encounter. So every time a doctor sees a patient, that is $150. So go to the FQHC. MedQuest, medical supplies, our DME provider. Their payment method is the Hawaii Non-Rural Medicare Fee Schedule. And our prosthetics provider is the Hawaii Medicare Fee Schedule as well. Hope Dialysis is Medicare copays and cost per dialysis treatment. So for Hope Dialysis, their claims are separated. We pay the copay for their Medicare patients, and we pay the full for their regular dialysis patients that are not Medicare. For Hope House, they have a daily fixed per diem rate. So it's a fixed rate every day per patient. For our Vision and orthodontics, it's a regular fee schedule. They have certain fees for certain services they provide, and that's what they charge us when they invoice us. Medicus is customary charges, which is whatever they would charge their population, that's what they're required to charge us. Now moving on to the claiming process, I have my colleague, our staff accountant, Mrs. Nemo Mangyel-Salavea, who will be explaining the claiming process because this is what she does on a daily basis. And up until a few weeks ago, she was the only one doing this portion of the finance. Nemo?
How's everyone doing today? Are you sure? Okay, just a refresh back, I wanted to do a quick ice break to see if you were all paying attention to my DH presentation. So by utilizing our fans, can we say true or false? Are we under PE or individual enrollment? PE? True, awesome. I also would like to have giveaways. So I hope you were paying attention to her slides, and whoever can answer this question will receive one of our giveaways this morning. What does FMAP stand for, the acronym FMAP? Can I get a raise of hand? Okay, can I get a mic here?
Federal contribution medical expenditure.
Is this, I know it's been increased. Does that mean for every dollar we claim on Medicaid, we only come up with a 17% match, local match, and 83% is the federal?
Thank you for the question. I thought you were raising your hand for the free giveaway, but we will get back to that and I'll have my DH answer that. Anybody can answer the question that I gave forth?
Federal, okay. Federal contribution medical expenditures or something.
Okay. Can I get another try? False. Nice try. Thank you.
It's the federal medical assistance percentage.
Awesome. Can we get a couple hands? Another one that she also presented was the CHIP, the acronym CHIP. Anybody can give me what that stands for? Okay, I have a, yeah, awesome. A+ or NEA, so our college student up on the second floor. Can we get that up there? Yes. So one more giveaway. Who was our keynote speaker yesterday? Sorry, raise our hands just like we're in school.
Dr. Tar.
Yay. Thank you. Now that I have your undivided attention, I would like to present on our claiming process. As stated by my DH, our goal during our claiming process is to ensure the compliance with eligibility requirements. Proper documentation is facilitated so we can have a timely payment presented. The first step into claiming process, rewind. Talofa lava. Itopa ia matoma malu lalo leo oile nei tula. Ai la tamwhai atu le nei au ona whatauwaa. E wha mamalama atili atu. Inga inga I tono mātou mtanga luenga. Wa whatinonga o pe menge. E wha pe nao to ninga ai tato pili o lo wha asau tono mātou mtanga luenga. With that said, I am Nimo Mangeo Salavea, and I'm our staff accountant, and I'm gonna present on the claiming process. The first step into the claiming process is identifying the bill or invoice submitted to our office. When that is done, we then go through the review and screening of the bills or invoices that is sent forth our program. What does that intake? We have to go through these invoices individually, thoroughly review and screen that each beneficiary that we receive the payments or the bills are registered or enrolled in our Medicaid program. Once that is established, we then work together to process the invoice by compiling into our vouchers. We have this very sophisticated automated system that we use, which is me. I manually input all these invoices that are submitted to our office. Once all of that is compiled into a voucher, it is then given into our internal approval process, which is first, we hand it over to our DH for the first initial approval. Once she makes sure that all the accounts are correct, for each provider, as she mentioned, there are different percentages that we use for claiming process. So we have to make sure that each claim or provider that submits, that we use the correct percentages for the claiming of the voucher. Also, we also make sure that that's why we double, triple, and make sure that everything is processed correctly. After DH approval of payment, it's then submitted to our director or deputy director for final administrative approval. That is making sure all our I's are dotted, T's are crossed before the routing process. Before it goes into the routing process, I then input this into our tracker, where this is where we input of whatever keeps track of whatever goes in and out of our office from beginning to the end. Next slide. Okay. The first stop of our claiming process or the routing is budget. Budget is where the encumbrance is where the budget is where it's encumbered. The budget analyst's approval, they review and make sure that the funds are drawn down and the exact amount are drawn down as it's stated on the voucher. Usually if the voucher exceeds $5,000, it requires the director or deputy director's signature. If it's less, our budget analyst can proceed with the approval. Once we get the approval from the budget office, it is then picked up, taken back to our office to make those copies before we head to accounts payable. Accounts payable is where we drop it off, have our vouchers. The originals will be dropped off with accounts payable, and our copy have the stamp receive on it. Once that is completed, we then bring it back to the office, upload it to our tracking system, making sure that everything is up. We have our hard copy and digital copies for us to reference to in case of any hiccups. Once that is completed, our job does not end there. The fully executed voucher is uploaded, but then this is where the fun begins. The fun begins is us consistently continuing to follow up with our payments. Just as you are calling and asking for your payments, we are also calling and asking for your payments as well. By doing so, we are sending out aging reports to the Treasury as a friendly reminder of what is still awaiting payments. Yes, at times, they may tend to, well, if they see us or our admin team who we work hand in hand with to also push our payments, they say, okay, lalasao, koikiki already, koikiki, check back tomorrow. For sure, when they say check back tomorrow, you'll see us tomorrow. Because we have to keep the good relationship we have with our providers. And with that said, I would like to extend my appreciation to all our beneficiaries and our providers for your patience with dealing with our claiming process. So remember, with our tracking system, we know wherever our voucher is at, from beginning till the end. Thank you.
Thank you, Nemo, for that in-depth and detailed explanation of our process. So I hope that gives you somewhat of an understanding of what we go through as we process claims and the waiting period we have. If we could issue checks right out of our office, you would get your check the same day. But unfortunately, we have to go through the process of the government, and we also subject to the local match, which we all know takes some time. That segues me right into our local match portion. But before I talk about our local match, I want to get into the nitty-gritty of our PE percentages. So American Samoa is the only agency that operates under presumptive eligibility, the PE model, while all others, even the other territories, use individual enrollment. Because of the PE model, when we process reimbursement, when NEMO processes the reimbursement, we have to calculate the MAP, the CHIP, the emergency together for all eligible claims, regardless of whether we know it's a child or an adult. In the traditional Medicaid world, anyone under 21, their claims are charged directly under CHIP. Anyone over 21, their claims are charged directly under MAP. Medicare has a different percentage, but because we don't do individual eligibility enrollment, all these percentages have to be lumped up into one formula. And so when we claim a $100 bill, we calculate the MAP, we calculate the CHIP, we calculate the emergency, and then we subtract all that from the total, and that's what we get with the local match. In addition to the PE, there's also the Federal Medical Assistance Percentage, also known as the FMAP. We covered it earlier in the presentation. This determines the federal government's share of the Medicaid spending in each state, ranging from 50% statutory minimum to 83% maximum. The way this percentage is calculated is based on a formula that considers each state's average per capita income relative to the national average. States with lower per capita incomes typically have higher FMAPs, and then vice versa. So for American Samoa, our FMAP is 83%, which is the max FMAP because our per capita income is one of the lowest, if not the lowest. For states like California, they have a 50% FMAP. And so for every dollar, 50% comes from federal and 50% from the state fund. The FMAP, I think it's important to know that it can be adjusted during economic downturns for specific circumstances like disaster relief. A good example of this would be COVID years. During these years, American Samoa received an adjusted FMAP of plus 6.2%, taking our 83% FMAP to 89.2. In some cases, like in 2019, during the end of the ACA funding, we were able to use 100% FMAP, but those variations aren't permanent and they're only attached to disaster relief. So once the public health emergency period ends, we revert back to the 83%. For the Children's Health Insurance Program, they have a permanent 85% percentage FMAP. So we have, this is where it can get a little confusing or a lot of confusing. We have the PE claiming percentages for MAP, CHIP, and emergency. We have the enhanced FMAP of 85% for CHIP, and then we have the regular FMAP of 83 for all others. When we combine these percentages, we get what is known specifically to American Samoa as the true FMAP. So this is calculated by the following formula. We have the MAP PE added to the emergency PE multiplied by the FMAP. That is our MAP federal portion. Then for the CHIP federal portion, we have the CHIP PE multiplied by the CHIP FMAP, and that is our CHIP federal portion. Now, whatever the total claim is, we subtract the MAP federal portion, the CHIP federal portion, and that's what our local match is, our true local match. So according to our claiming percentages for this year, our MAP percentage is 39.70. The CHIP PE percentage is 9.27. Emergency is 32.58%, and Medicare is 90.14. Just to give you some reference of different states receiving different FMAPs, Hawaii's FMAP is 59%, Georgia is 66%, Florida is 57%. Even though we have the 83%, we cannot claim the full 83% because of the PE. So when calculating the reimbursement for any given provider, we take the total claim, apply the PE, and then apply the FMAP. And it's a formula specific to American Samoa because we don't do individual enrollment. So to give you an example, Guam also has an 83% FMAP, but they do individual enrollment. So if Guam has a $100 bill, 83% can be claimed on their federal, and 17% is their territorial or state share, which is their local match. Whereas American Samoa, we have to apply all these percentages before we apply the FMAP. So our $100 bill would mean only $67 can be claimed from the federal, while 32 is local if we apply these percentages. So like Limo said, different services have different calculations. A Medicare calculation is different from a Medisys calculation, is different from a DME calculation. So we have to make sure that we are claiming the correct percentages for each bill we receive, And without an actual system to do this, we have to do it manually, and it's very tedious. So it is incumbent on us to check and double check and triple check and quadruple check our percentages, because the last thing we want is for an audit to find that we've claimed incorrectly and have to pay back the federal government. So whether you're a provider, a beneficiary, or a government stakeholder that's part of our routing process, the Medicaid finances affect us all. And at the end of the day, our formula is simple: no money, no service. And to be more specific, no local match, no services. This is why our local match account is our most precious account. This is why all you hear from us is local match, local match, local match. Having an adequate local match to support the federal Medicaid grants each year helps us to achieve the agency's goals and the public's goals, and ensures uninterrupted access to care for Medicaid beneficiaries and otherwise non-ineligible population. Once the local match is depleted, which we observed in FY24, where we had to suspend services, it's the sad reality of our program, but it is the reality. It was a sad year for Medicaid, and it just drives home the point that our federal dollars, while we have an abundance of federal dollars, they're only as good as our local match and what we can draw down. So until Medicaid receives enough local match to draw down the full federal funds, we continue to return millions upon millions of dollars to CMS, and it's not for lack of necessity. Imagine how we could transform our local healthcare if we had the ability to draw down the full 90+ million in federal funds. Which brings me to my final point. Oh, maybe I should. LBJ operates under a CPE methodology. To avoid getting into the details of what this means, the bottom line is there is no local match required for Medicaid claims. Whatever LBJ submits to us, applying the calculation, that's what they get fully federal funded. There is no local match for LBJ. And this is where our focus should be, not only because they are the only hospital, which is definitely a major factor, but because they are in the best position to draw down federal funds without burdening our local dollars. Now, how we're going to do this is where we need to get creative, and I assure you conversations are happening. Since Honorable Governor and First Lady just walked in, I want to repeat my local match presentation.
Please repeat the local match. Government's here.
Okay. So I'm sorry if you're going to hear this again, but the right ears are in the building today. Medicaid finance affects us all. Our formula is simple: no money, no services. To be more specific, no local match, no services. This is why our local match account is our most precious account. And this is why you continue to hear from us, local match, local match, local match. Having an adequate local match to support the federal Medicaid grants each year helps us to achieve the agency's goals, the public's goals, and our healthcare industry goals. And it ensures uninterrupted access to care for Medicaid beneficiaries and otherwise ineligible population alike. In 2024, we witnessed the Medicaid program shut down. This is something I do not want to experience again because it affected a lot of our beneficiaries. Actually, it affected everyone in this room and our people. Without the local dollars, we are unable to draw on federal dollars. And without the federal dollars, we can't pay our bills. And without that money, we can't provide access to services to our community. So, what's our favorite word for today? Local match. Thank you, Governor. Okay, so if you want, you can take a picture of this slide because we will be referencing it in our class activity right now. So you can take a picture or write down the percentages. And we'll go over some scenarios just so you can get a feel. Just like last year, we changed the formula's the same, but the numbers are different. So you get to do a little brain activity today. So I'll give you a few seconds to take a picture of this or write the percentages down. Are we good? All right, let's get into it. Let's do some math. Our first exercise is a Medicist claim worth $100. Using your percentages from the previous slide, input it into this calculation and figure out what our local portion would be. What the MAP portion, what the federal portion versus the local portion would be. So just to walk you through it, you have the total claim, which is $100, multiplied by the sum of the MAP PE and emergency PE, multiplied by the FMAP, 83%. That's where you get the MAP portion. Then you take the total claim again, $100, multiply by the CHIP PE, multiply by the CHIP FMAP, 85%, and that's where you'll get the CHIP federal contribution. And then finally, you take the total claim, $100, subtract the MAP federal portion, subtract the CHIP federal portion, and that's what you get for local match. There is a prize for this, so once you get your totals, just raise your hand and someone will come around.
Mautua ia le turanga e mangalo se leo a ofengai tato a fia ma tato activity o te tula I lava ma whaanoano. Whai masui o le te mai tai whaatono e mai se nei ofisa man mamado mwhaen whaatasi mai. Whaafeiloa I alo I atuai le taunu umai ala na fionga ko vansini. Ia e mai se whatua. Thank you so much, Honorable Governor and First Lady, for gracing us with your presence. How about a round of applause? And we are now back to our activity. Rough time.
I'm glad to see everybody struggling because this is our struggle every year, every day. Okay, we have a...
Based on the percentages I have, if we get a $100 bill from a provider, federal percentage would be $83, local $17.
That's Guam's calculation, but thank you, Tassie, Lola. we have any takers, or should I move on? Okay, we have one in the back. Sandy? There's no wrong answer today because we're not actually claiming, so don't worry.
Okay, I have 57.97 for what is it? Medicaid, MAP, and 42 for local match.
Sorry, incorrect. False. We have one in the back. Maureen?
I think it's $11 local match.
I'm sorry, how much?
11?
11? No, I'm sorry. Don't apply for Medicaid finance. Just kidding.
MAP federal portion, I got $59.99. CHIP claim is $78.795. I didn't get the local match.
And what was your local?
I didn't get it. I know it's less than.
Okay, you're on the right track. So you just subtract all that and you get the local, which is about $32.
Okay.
Yeah.
I
So
see.
good job. Can we get, I'm sorry, what's your name?
Joyce.
Can we get Joyce a Medicaid application, please? Thank you. Okay, so this is one of our hardest formulas. And so I don't blame anyone for being confused because this is just day one of instruction. So maybe next year we'll do better. This is our second exercise. It's one of our easiest formulas, so I expect more hands raised. This is a Medicare copay. And the formula is pretty straightforward. So the copay is Medicare covers 80% of the bill, and we get the remaining 10%. Usually they submit the 10% to the patient, and the patient will just turn it into us for payment. If we do get a copay bill, we are only responsible for that portion that the patient is responsible for. So say the copay bill is $700. We would take the total bill, $700, multiply the Medicare PE, which is 90.14, and then we multiply the FMAP of 83%, which is the federal portion. Then we take that total claim minus the federal portion, and we get our local match. Medicare, the percentage, the PE percentage for Medicare is really high, so our local match impact is very low, which is why we love our Medicare patients. So if you want, you can participate in this, 700 times Medicare PE times FMAP, and then you subtract that from the total claim. What is the local match? Terry, you want to take a jab at it?
The local match would be 69.02.
What? I'm sorry, go ahead, repeat.
69.02.
69.0. That is correct. Thank you, Terry. Can we get Terry? Okay, and that concludes the finance portion. If you want to do more math activities, I'll be in the back. And we'll open the floor up to Q&As.
Hey, Nina, do we have any questions submitted via the QR code? If not, the floor is open to any questions that you might have regarding the finance presentation, the lovely and very informational math course that Wilhelmina just conducted for us. Gila?
Thank you. So I've always wondered, is the local match a figure in the resolution of FONO, or is it actual money? For example, years ago when I was going to LBJ, I would pay the $20. Would that be part of the local match, or no? It's a declaration from FONO and the state plan, how much matches, and how do you account for it? Like, do you add up all the, like FONO says, okay, there is $90 million or 2.6, whatever you had said, we increase it to $15 million. How do you account for it that, yes, CMSC, we have already spent so much local match? Can you explain that part? I don't know. And what is the connection between the charges that we pay to LBJ with the local match?
So the local, LBJ doesn't require a local match portion for their expenditures. Because their expenditures are already certified as public expenditures, CMS counts that as the local match.
So we don't need to prove it?
No, for LBJ only, no.
So is that like cream from top of the bucket? They just get that $20 and for their expenses, the overhead expenses?
Yes, whatever LBJ charges, I'm not familiar with their schedule of fees, but yes, we do reimburse them, but whatever they charge the patient, it most likely facility fees or other overcharges.
But is there a way to account for matching, like in the bookkeeping of the monies that providers pay or you deduct from the claim to say that's a local match? Is there a way of an accountability that, yes, you reach to the maximum of the year of so much, $6 million? I don't know how in real world, is that real money or is just on the paper, a figure on the paper?
The $6 million.
6 million.
So the $6 million is the budget ceiling we are allowed to tap into the federal, the local funds. Now those are subject to availability. If the revenues are slow, then the local funds are slow. And so right now that's the issue we're having is getting our local payments out. But if the revenues are on track with the budget, then it shouldn't be a problem.
So the $100 bill that a provider sends you,
yes,
you don't actually pay them if there is non-local funds for that portion of the local match?
Yes. If there's no local fund, we do incorporate it into the formula, and then we separate what's federal and what's local. We do pay the federal and we do pay the local upon availability of the local funds. So there's a delay in the local, but it will get paid.
Okay, and is it part of the budget department activity to show how much local funds has been paid or not paid yet?
We keep track of it.
Yeah.
Treasury keeps track of it, and budget also. Yes.
Can I add, please? Sorry. Thank you, Gina, for your question. I think it's important to understand that we pay providers differently. So LBJ, being our main provider, is reimbursed on a certified public expenditure model. What that means is CPE only goes to hospitals. That's only allowed for hospitals. And because of our presumptive eligibility, part of our state plan, we are allowed to basically give funds to LBJ without having to go through these formalities that we do with our local providers. And so every provider here, being local versus our off-island providers, they're all paid differently except for LBJ and DOH because they are under the Certified Public Expenditures model. Now, to help you understand the federal funding, we have close to $100 million that is allotted to us every year from the federal government. That is one allotment per year. So that's as much as the federal government will give us, and that's a capped amount for us. In order to draw down that amount, we need a comparable local match, meaning it has to match back to that percentage that Mina had described for us. What we're saying is we don't have enough local match generated or given to Medicaid in order for us to draw down all of that funding. And because of that, every year we return millions upon millions of dollars back to the federal government. Now understand, we never had $100 million for the whole 43 years we've had Medicaid. That increase just happened prior to COVID. We were operating on $13 million as a territory from the federal government for a long time. And the local match went from 0 to $1 million 1 year, then 2 million to 4 million. Finally, we're now at $6 million. In order to utilize all of the federal funds, however, we need $30 million to do that. But guess what? That $30 million is going to get us more services for the eligible population, not for the ineligible population that we talked about. And we have already allocated funds or portion of those local match funds to help our ineligible population, which is our permanent residents, our CAs, our AAs, those who are ineligible for this federal program. So the services that are happening at LBJ, they have their method and their programs. We are reimbursing them, but it's not the same way we do for local providers as well as our off-island providers. Hope that makes sense.
Good morning, Talofa Lava. My name is Catherine McCutcheon, and I represent a nonprofit community-based organization that is providing senior services and home care. My question to you, Madam Director, is it's very clear over yesterday and today that the issue is the lack of local match. So my question is, have there been conversations between your office, the governor's office, Medicaid, rural community, federal agencies, other states and territories that are in the same predicament as ours to identify other opportunities to generate revenue? Because it seems like the onus is being put on the FONO to come up with a legislative measure to create the revenue, the 30 million that you're speaking to. And we know that any bill that the FONO would introduce would entail taxes or some sort of other revenue measure that would put that back on the people. But are there committees or conversations at a higher level where you're talking about what are other states and territory, rural communities, what are they doing to generate that local match? And are there conversations about a way that we as a people, as a country, every working adult can contribute into a pot that's similar to the retirement fund that then is operated and provides a financing mechanism that provides you with that match that is maintained by the government, but everybody in the territory, let's say working adults, pays a portion of it. Because if you were to poll the community, they would be willing to contribute to that. as long as it's in an organized fashion. I don't know that taxes would generate the type of revenue that you're looking for, and we don't have a tax base to support that. So that's my question is, are there conversations, or are we gonna go for another year and another year where we're pushing for a local match, but who is coming up and who is doing the deep dive into that information to provide options, to provide concrete options to the governor, to the FONO, on what they can come up with and support on a local level?
Thank you for your passion. Appreciate it. Regarding conversations happening, yes, they have been ongoing. Even prior to my position here as Medicaid director, it has always been a cry from Medicaid to get more local match. As far as Medicaid's role is not to generate revenue for this economy. That's not my job. My job is to use the funds that are available to us and maximize that utilization to access health care. There are conversations. Right now, our current source of funding comes out of special programs, which is under the governor's office. And that is not a secure source of funding, you know, and $6 million, I'm not quite sure how they come up with, meaning the FONO, because they are the governing body that sets the appropriations for the budget every year. But we have asked, and it's a reality that this country is not generating enough funding to do this. And so it takes all of us to come together to come up with ideas. These conversations have been ongoing and ongoing, but until American Samoa makes medical invoices a priority or healthcare a priority, we will continue to get in line and ask for our appropriations just like the rest of the agencies do in order to operate. And so for that reason, I'm grateful the governor is here because he has been working hard to get us that increased local match funding. It might not happen in this fiscal year, but it may happen in next fiscal year. Thank you.
I'd like to
I think Governor wants to add. Thank you, Governor.
Katie, that's a very good question. You mentioned the matching fund that we need, and Director said that we need about $30 million to access the almost $100 million. And the FONO in our budget passed, and I signed it, $6 million, which only access a certain percentage. So we need 24 million added to the 6 million to have access to the rest. Now, when I came in January last year, one of the first questions I asked my treasurer at the time and the budget people, how much money does ASG have? And secondly, how much money does ASG owe or debt? The answer I got was, Governor, we don't know. Okay? So at the time I thought, okay, the ASG employees are about 7,000 people. How much is the budget? Do we pay for the people? So when I came in the 2025 budget was 166 million for local funds. The rest of the budget, altogether with the federal funds, was about 733 million. So only 166 million was local fund. Now remember, a budget is just a budget. Now through the years, the 4 quarters, you gotta have revenues and you have your expenditures, so it has to match. So I told the budget people, go back all the way from Governor Coleman in 1977, come all the way to Governor Pula, 2025. Tell me the trend of the budget through all these years. Because I wanted to see what's the trend of the revenues up and down. So usually those people who are good with money, they usually say 4 years back, 5 years back, see the trend. Is it going up or is it going down? And that's how you kind of focus your budget. I was told that in the last 6 years by my then treasurer, that American Samoa government received almost $2 billion. This is COVID money, other funding, ARPA funding, coming all the way back. Now, I'm going to try to make this a short answer. So our government was already in the red when I came in 2025. So we go all through the year of 2025, and now we began the budget of 2026 in October 1st. What happened was I cut the budget of the local budget, which is the important part of the budget, 25 million. So instead of 166 million, it went down minus 25 to what? 141 million. And why did I cut the budget? 25 million? Because the revenues of the past years were coming down. So I don't want to raise the budget. I was hoping we could meet the 166 by the end of fiscal year 25, and we didn't. So I was correct. So that's why I cut the budget 25 years. But mind you, during the budget discussions with the funnel, well, I can only see the Senate people because they had TV. You can see their hearings, but we don't see what's going on in the House. So in the Senate, I saw not a single one senator raised, why did the governor cut the budget 25 million? Not a single one in the hearings that I saw. The focus was on, but the directors that went, they got scolded, they got demeaned, and all this kind of stuff, but that's neither here nor there. So we're preparing for 27 budget. Now we're almost coming to the second quarter, the end of the second quarter. The other thing the FONO did was they cut the budget of every director that are under line agencies in the governor's office, including the Medicaid director. They brought the budget to me the last day, September 30th, before October 1st at 3:30 p.m. The deadline is midnight. I didn't have time to negotiate with the funnel because they brought it in the last minute. Why did you cut all the directors' budget under the governor's office? How am I going to pay these people? So I wrote a sentence down when I signed the budget, going back to the funnel. I will use my constitutional right to spend the money you've cut, because that is the governor's responsibilities, not the funnel's. The funnel cut the budget. So now, yesterday, listening to the funnel joint resolution, they want to take me to court. I'm not saying this because I want to fight the funnel. We have money issues. Those are the more important issues to me, like Medicaid, like what we're talking about today. Like you mentioned, the retirement fund. Those are important issues. Not because my chief of staff yelled, so, if the funnel's going to take us to court, no, we'll go to court. And it's not a fight like who's got more marbles, right? It's not about ego. It's about the right to do the right thing. Now, in that particular hearing, my chief of staff was trying to answer a question, and some of those questions was about why the governor is breaking the law by paying his directors instead of following the law they said they cut. Well, my point of view is, none of the directors in the line agencies did anything wrong. How are they going to feed their families? My administration followed the Lemanu administration, how much they were paid and all that kind of stuff. Same thing that Lolo. But why does the Fono now want my line agency directors to come and be confirmed when they were not confirmed in the last administration? So it's a matter of fairness. That's it. I decided I'm going to pay these people because they didn't do anything wrong. If the Fono don't like the fact that I didn't bring the people they're asking to be confirmed, we can work that out. And that's why whenever I was asked by the Fono, I said, yes, they're coming. Because I was under the assumption they were going to be confirmed. As a matter of fact, they were all ready to be confirmed, but they didn't take out their names. Well, anyway, that's neither here nor there. But the point I'm trying to make is, our government do need funding. We depend so much to the federal government that it's amazing that we are blessed. We are blessed that we do receive federal funding in order for us to survive or to make ends meet. The government needs funding. Okay, have we discussed the issue? I was thinking maybe it's time to have a lottery to raise funds. Well, I don't know. Maybe all the ministers will say, hey, you want to gamble? Right? So there are ways, and I'd love to work with the funnel to figure out ways to raise revenues. Some have mentioned not only excise tax, but sales tax. All these things we have to look into. So anyway, to answer the question, it is not easy. But we're trying to work at it. Just because the Fono now wants to take my administration to court doesn't mean I don't want to reach out. I reached out. I just got back from Hawaii Monday, sent an invitation to the Fono leaders to meet with me today. I just got a letter before I got here, said, no, we don't want to meet with you if you're just going to come talk about your chief of staff. That's not what my invitation was about. I want to sit down and talk about retirement fund, revenue measures, and people being confirmed. Anyway, so yes, there are continued conversations. And I am going to continue to work with the Fono. If they continue to want to take us to court, we'll go to court. But my administration want to do the right thing and the best thing that we can. So, Kalingali Katie. Oleh kausuan ka kumanguya.
I'd also like to add to your question, Katie. There's no local match requirement for LBJ CPE. They are in the best position to access the federal dollars without burdening the local fund. Because the reality is, our local match comes from the general fund, and we share this fund with the rest of ASG. So we do need to support our LBJ efforts, whatever they are, to increase funding so they can provide increased services and in turn submit an increased CPE reimbursement to us because they don't require the local match. So LBJ can draw down the rest of that money if they had the claims to do it, but they don't. And that's our dilemma right now. Even though they're subject to the PE, the bottom line is they don't require local match. And so a lot of our efforts, my personal belief is, a lot of our efforts should center around LBJ's efforts and in support of LBJ's efforts to increase their services. The PE involves AG's office, DOC, Census office. These agencies also need to be at the table because their work and their data directly affect the PE, which in turn directly affects LBJ. But bottom line is they're in the best position to draw down these federal funds without requiring a local match. To further expand on that, last year we didn't use all our local match that was allotted to us. That's because we didn't have enough expenditures. So giving us 30 million to draw down this 90 million, and we don't have enough expenditures to spend this money, will just end up being returned to the federal government. And so there are a lot of moving parts in this dilemma, and there are a lot of conversations that need to happen, but I can attest that the conversations are happening. I had the distinct honor of sitting in one of them at the governor's office. So they are happening. It's just a matter of figuring out the best way forward for the territory. I have another question. Mrs. Early?
LBJ, which doesn't require the match. What does that include? Does it include the delivery of care? Does it include the salaries of the physicians? Does it include the medical supplies?
It includes all of that.
All
and
of
emergency services as well.
Okay. Can we find out why our care is zilch with the hospital because they don't pay their bills, and yet they're given money. I mean, they're being paid, reimbursed or paid with their total expenditures. If the supplies are covered, why are there a supply shortage? If the salaries are covered, why is a physician shortage? How do we figure that out?
I believe that's a conversation with LBJ, but just to further clarify, they're not reimbursed dollar for dollar. So if to simplify it, if their CPE total cost is $100, we apply the PE percentages.
Okay, so your PE percentages, your reimbursement methodology is based on what? Is it's kind of like if it's $100, what do they get reimbursed for or paid for?
So if the total CPE is $100, we apply the PE percentages and the FMAPs, and they'll get $68, about $67 on the dollar, on the 100.
Okay.
So 67 cents on the dollar.
And okay, so that's from the federal?
Yes.
And as far as the match?
The match portion, they're not required to match because their expenditures are already certified as public expenditures.
Okay, I see that, but that match is based out of our pockets, is that correct?
Yeah, so LBJ covers the cost of that match out of whatever their funding pot is.
Whatever their funding. It still doesn't make sense to me. Okay, thank you.
So LBJ eats the cost of the local match.
Yes.
The $32,
yes,
they pay it out of wherever they...
Where do they get that 32?
Ask LBJ.
The fees? The hospital fees or?
Yeah, possibly. I mean...
Facility and love and affection? No, seriously, I don't understand. They need the full 100. Okay, I guess that didn't.
If we
Thank
didn't do
you.
PE, they would get the full 100, but they would also not be able to claim for half of the population they're claiming for. So it would get reduced to $50
Got
versus
you.
$68 under PE.
Okay.
And just to add on to Finance Division's claim on PE, because it also relates to the nonprofit question, sorry, ma'am, EPIC. There are conversations happening at the territorial level. And by territories, I mean all the US territories. We were just together with the National Association of Medicaid Directors for all the territories, which includes USVI, Puerto Rico, Guam, Saipan, CNMI, and American Samoa. Now, the conversations are really about how do we generate revenue as a small island territory? How can we push the envelope with the Hill on removing the caps so that we can just fully utilize all the federal government dollars that are given to the territories? But it all goes back to the disadvantage in the territories' eyes. Our disadvantage is being under PE. Because we don't have, although we do share the same problems as the other territories in terms of we're all remotely located, we're small island territories, we do not have the local revenue that the states, say California, might have, but they are able to, they have exports. They have USVI in Puerto Rico, they're so far ahead of us. But Guam, they are now individually, they have IE, and they're able to claim those dollars, the full 83% that we're unable to claim because we're still under PE. Now, the question that remains, then why is Medicaid still under PE? And it goes back to Mina's presentation, because our duty is to all the people that we cover. We're able to cover a whole lot more of our population under PE than we are if we were to move into IE. Now, once we move into IE, it all goes back, we'll be able to cover a number of services, but for a very small, specific group of people that is outlined by the federal government. And so it's seen as a disadvantage, and that's one of the reasons why we have been hesitant. We've done feasibility studies into, okay, what would we look like as a territory if we move into individual enrollment? Obviously, as Mina mentioned, it would be so much easier to the Medicaid office because we won't be doing all the percentages. We would just be, okay, apply to 83 and then fork out this little local match of 17%. However, again, the duty is to the people and providing health care for everyone who are here in the territory.
Kvzk, I'd like to build on what Deputy said. Until we have alternative solutions for insurance, we will continue to remain with presumptive eligibility. You have to remember, Medicaid is an insurance program. It's insurance coverage that is offered to us by our federal partners. So until we have alternative options for health insurance, for example, there is a population, the veterans, they take care of their own. They have the TRICARE, that's an insurance. There are a few private providers or private businesses in the private sector that also provide a health insurance to their employees, like ASPA and some others, I can't remember right now. But these are all different health insurance solutions that are offered here. But our ineligible population, what do they have? What other insurance do they have? They don't. And so we either remove that by going from PE and transitioning to individual enrollment, without having a solution or an option for them to fall back on, that would really hurt our healthcare system. Or we remain steadfast with the PE and do all of, you think I want my team chasing money and doing all these percentages? We are still a manually based office. There are so many ways to modernize our systems, to save us time, to make us more accurate in our reporting, and yet we continue to be manually based. This is hard work that we're doing here. But it's like, what are the trade-offs? What does American Samoa want? Do we want to let our ineligible population, which is half of the population, fend for themselves right now? Because we are not in that position to do so. Or we carry on until we can find the right solution for us. But please remember, we are really an insurance program. And regarding our federal MAP, we have to look at it as an investment. For every dollar we spend, we're getting $4 back. No other program is doing that. That's what our legislatures need to understand. And so if you're asking, where are we having the conversations? Oh my gosh, we're all talked out. But I think this summit, we are each a constituent of this territory. It is upon each of us to speak up. Speak to your faipule, speak to our senators, and tell them your issues and your problems. We see it every day. We see the families who have to be separated because they need the health care. You've got a father here working for one of our agencies, and his newly wife and baby are in Hawaii trying to make ends meet. Because they can't come back here because we don't provide the medication, and he can't give up his job here because he can't provide for his family. And who is she burdening? She doesn't always have family in Hawaii. She's burdening the Hawaii system now. So these are all the conversations we're having right now. We are partnering with our federal partners, talking about ways to be innovative and creative to utilize this fund. Because imagine this, we could lose it, and then we would be in a world of hurt here in American Samoa. So these are the conversations that are happening. This is what keeps us up at night. We want to provide access to healthcare for our people. We want so much to do that we are being so creative, finding loopholes, trying to get people to New Zealand, to Hawaii. And that's where I feel like this summit is most effective if we take what we learn here and then go back into your communities, go back to our legislators and speak about it.
I don't have a question.
Sorry,
Recommendation.
Just a quick question. Does CHIP pay towards the autism programs for kids?
Sorry,
Does CHIP pay towards programs for autistic kids?
So the way, under PE, the way CHIP works is we don't individually identify children under 21. We do in a sense, but in the formula, all claims are calculated the same. A child, an adult, under Medicare age, they're all calculated with the same formula, MAP, CHIP, local. Yeah, we can't separate the CHIP because of PE. We don't do individual enrollment. Yeah. Wait, sorry, Molly had a question here.
I don't have a question. Recommendation 1. Si kwe vai fa po febo ye comprehensive health coverage and malo liva wadivanka for families. 2. Family moli. The community needs to understand this, especially the formula there in this presentation to deliver it in Psalm 1, where all the people understand, especially the old folks who are depending on Medicaid and Medicare. If all families can pay car insurance why not look at family insurance to assist the Medicaid? It's hard work, but our mindset has been, what dependent we keep saying that's their job. What are we doing? So we depend so much on this. We have a role to do, we have a part to play if we are looking at our health.
Thank you, Molly. There's a question up front, please. Somebody.
Tua maleava man minga o tawai. O haulela fasamoa langa lele tele la nanu te wase. A almele saunoa maiea. Spulu tau sanga ma no forma lo to alu to low way Hawaii. Ona almela le saunoa maiea ya te mai tai lunga. Le se insure tato. I know for Hawaii na ia mawai residency Hawaii. Fai atu lola mato mu mai, la fautu e ave ese le sosoani Hawaii. Awautu la i atu. Sisila tatu atu nuu. Taini umai ave ia ulalo alfa ata tu loa. Se laulima sfulu afe. Fia sfulu afe. O fa pele atalo fa tato malo. Le tioa fa fena. A fai to alua ma ua peto tolu peto a fai maual mailia. Feme mai ele se lau lima sepulu a fepe ale oi Hawaii. Au fai atu mato ainga. Talo fai. Na le mui o tatu atu nuu. Le anga fan mai. Le anga fo mai. Feme ave tupe. A se yo mai la tu loa ta o oto ilano nsini lea. Se lau lima sepulu a fe. Tau vaile ye le tai lava tupe tatu malo. Le tai. Tau fai atu atele o mato we oi fafo. Ia mātou lava tupe male Medicare. Medicare na sosoani tele ia te au. Ia o lau sia utala na. Alo whanoa noa ia wa. A whai atu nei tangata na atu. Oi talo whai. Lua mai whai sengo tala wai. Ioi. A wha whee leanga o kako whan mai. I don't think o leanga whan mai. Wha whenga a wholes lau lima sepuru a whele ka kia ia ulalo. Isu enga tu lo wale atu nuu. Isu enga lo cancer. A lea lava e whamai a tātou o leanga whamai o leanga. Se longa miliona, biliona, na mwhaile tātou na whaile like Queens. A vai a tō masini leo te tau toi lalo, salo pe 4 miliona tau. Whawhena fortia tātou malo. Na o si awa popo i ngā le share atu lau experience. I tau tu umai hei fo il tātou wita ma tātou mui whapea. O leanga i nei no. E le tau mo fia ia whaafitai lama molo wap noa langa la tau tala umi lom tua.
Whaafitai lama mo lewa noa. O nei fo imta upu tatu tala noa ina. O mta upu sidi mta ua. Ai, mana tua fo i tau sanga wa mabai tili. Ili ima whaia tatu na whaile local match. So I think it's about time for the community to come together and help generating some revenues to help out with this local match. Mangkula ba au taimi a o treasure le a fionga ya mangale sa introduce ay le pili a tax uma organization like fai bingo or raffles mai don with society tax and malo. So I don't know if it's still in excess, but I think it's time for us to come together and do that. I know whalonga tu le tau noanga fo o vansili. E tau na mafau tātou se lot. Tu inga mea la whapia. A whaila la whaile tātou iam tā upu lawa nga i tātou Medicaid. A whai fo i set pili. Ia mauti noa lava. O le revenue le sau le mea le la whainei. Adu sa o lava local matter. A tātou Medicaid. It's very important because o le mea tau ai soi fuo tangata. Ia o se o ngā teipi tātou mta upu whaftai.
We have one more.
Thank you. Oh, hello. I just want to share with you something that last year, about this time, maybe after Flag Day, I became aware of people who needed to go to Hawaii to get treatment, and they didn't go. And the outcomes here were not good. And it hurt my heart. And so, with my two little ladies that work with me, we decided to do something. And so we did ornaments. We put together and made ornaments from American Samoa for Christmas, for the Christmas trees. And we sold them for $10 and $15 each everywhere we went. At the end of the Christmas season last year, we had made $20,000. Thank you. It's really just a drop in the bucket, and I know that. But the fact is that that's $20,000 more than we had, right? We put together a corporation that is 501c3, which means that every dime we make goes into the pot. Salaries don't come out of that. We're living in the police house, one of the police houses, so we don't have to pay rent. My point is, it's possible. It's possible for, this is a big problem, but it's possible for everybody to think of what you can do. We chose Christmas ornaments because being born in Washington, D.C., they were lovely, they were beautiful. We couldn't afford to do those kind, but we did American Samoa kind. And so there are things we can do. We just need to think a little harder. We need to think a little harder, and we need to love a little more. And, you know, our 501c3 is called WAO, wow. We didn't really think about how it would sound. Wow. But it stands for We Are One. We are one. Because we are one. I love this island, I love this people. I'm so sorry for those who need help that we can't get here. But we have our little $20,000 pot, and we'll do them again this year. We'll do different Christmas ornaments. And so if you see us out hawking on the street or something, stop by and get an ornament. We would love for you to have one, but also it's going for a good cause. Thank you so much.
Okay, enough sad news. Let's talk good news. Whaftai level whantua, mas ngofie fo I lau, sauna anga man, manatu fo I tatu whasoa ne yaso. Ole, I'll speak English because some of you don't speak Samoan. Last month, February, I was in Washington, D.C. for the National Governors Association meetings. And we also had meetings of what we call IGIA. So it was the White House, President Trump's Director of Domestic Policy, and the Secretary of the Interior, Secretary Burgum. They're both co-chairs of this small group, where every year, around February winter meetings, the governors of the 50 states and us from the territories go to have the NGA, National Governors Association meetings, and then we also have the IGIA meeting just for the governors' territories. Now, in those meetings, our delegate, Uifatali, and all the other delegates, or congresswoman, congressman from Guam, CNMI, we meet together with the governors of the territories and the White House representative, as well as the Secretary of Interior. So we talk about these issues. And And that's why when I talked earlier about looking for funds, for money for our government, and that we are blessed, because I was talking to the governor of Hawaii, Governor Green, who came here last year on our Flag Day, and I said to Governor Green, you know, we're trying to work on insurance for our health insurance, and then you guys in Hawaii have a kind of a, you know, mind you, I think we all know Medicaid and Medicare were made for the 50 states, not for the US territories. We have so much smaller. So they always try to modify these laws they make for the states to try to fit us in. And so I want to say, during Falumavaenga, for folks who need us time, and all the folks who were in Congress, now we have Wifatali, they always try to push for us, not only American Samoa, but for the territories, to increase our federal funding, because, as Falitua said, you know, if we go to Hawaii or any state, you go to see a doctor, the insurance costs thousands. Just yesterday, I went to the dentist after work yesterday. I spent 3 hours, you know, Dr. Leota and the dentist, and they were all having fun fixing my teeth. And afterwards, I said, so how much does it cost? They say, it's free. I said, man, I pay $3,000 when I go to see my dentist over there. I practically fund his new boat with my insurance. But when they told me it's free, I figured, oh. And then she said, you know, Governor, the Fautasi race is coming up. Everybody's gonna get drunk and everything, so we're gonna have a lot of broken jaws coming to it. And that's one of the things we try to work on. And it's free. Well, and many of you know that a lot of things in life is not free, even freedom itself. And many of us throughout the years, we have said the deed of cession is that the federal government, or they pay for free health and free education, and we ceded our lands to the U.S. for protection. You know, I've worked in Washington over 40 years of my life, more time than my adult life here. And those folks don't know what that is. But what I want to tell you is opportunities like I have. Just last week I was in Hawaii. I went and talked to Governor Green again about their health insurance, how we in American Samoa can copy some of the things that they do or bring some of their expertise to help us with trying to figure things out. But we canceled our dinner and our meeting because of the flooding that was happening in North Shore. But he gave me a name of a staff that I've connected with one of my staff in the governor's office to try to have a Zoom and discuss these things. So what I want to say to all of you today, and I want to commend the Medicaid office or all the healthcare folks who are here who thought of and made this summit happen, because these are very important things to all of us. And I think sometimes we have to, like everybody is, I'm hearing saying, instead of complaining, step up and say, what can I do? Yeah? And I think that's the way we are here. And it's so true. Half our population are not eligible for Medicaid and Medicare, but we try to figure a way out to serve them as well, because they live here and they're part of our community. So anyway, I just want to say the good news is we're going to keep working at it. We're going to keep, you know, not to give up and say, been there, done that, maloloya. But, you know, we got a new generation coming up. We got new kids coming up. We got a lot of people in our diaspora, or diaspora, I never know what's the right pronunciation. But I tell you, there's a lot to look forward to. A lot to look forward to. I'm very confident, I'm very encouraged that things will get better, especially our health care. Yeah,
o te fia lango le manatu le sunga ya moli, pape foi le tina ya ese. It is high time that our community can make a significant contribution into this health insurance discussion. And I'm glad to hear that Governor Pula is having those discussions with Governor Green. I would hope that he also explore opportunities with Canada, because Canada is a self-insured country. And that's where I'm going with this, is whether or not there's an opportunity for American Samoa to create or pool money from our working population to be able to create a fund that would self-insure us. Then when you transition to IE, Medicaid can benefit 100% of those who are fully Medicaid eligible, and that should have 100% of their care covered. But the rest of, I'm not talking about the ineligible, but I'm talking about the higher income folks. It doesn't make sense that the higher income, medium to higher level income folks in our territory now, because we have a level of those who are medium to higher level income, that they're getting 100% free Medicare, medical care from the hospital, from DOH, when that Medicaid money should only and fully support those who are Medicaid eligible. For those who are medium to higher level, they should pay a copay. They can afford it. And in other states like Washington State, there is a policy that allows the state to withdraw wage taxes that goes right into funding long-term care for Washington State employees, anybody working in Washington State. So those are the kinds of ideas that I'm suggesting that be explored, be talked about. There has to be a team that does the homework and looks at those things and presents options. Yes, Madam Director, that is not your job, but I believe that your staff, with their working knowledge and all the meetings that you folks have with CMS, they understand the nuances of the system. So they would be the better people to be at the table to develop these recommendations for the governor and the legislators. Thank you very much.
Thank you, Katie. Tai lava mo saunoanga ua forsia fu ni tai au ala u pasa mo tula ua ua forsanga falonglongo tula ni tai au fa tai mana tu forsia so soani e fa pula tilim sa up e lesem sa up fa ngofi olem twa olem ta upu fa ngata ala la vai alu al focus akato le local match e ka kaulanga ngai ele kolu se fulu milionga e ngai am fanga draw down the rest of the money e fanga sa ya amlik Samoa alo falong longo fo ile kan message le fai le ngai el tsau sanga le na avele ongo milionga local match ile vanga le ai le fanga spend uma ai se a ele ausia e fai ngumela e mafai ai ona fa nga uman local match ai fa tai fo ilo falong longa ku tai al ni ala ele avangoa ele require ise local match it's a taula da fa tala no le ngola o le fal mai le ka o ele sa nga mina sa ole ya mina le fal mai afa pele ele ni le fal mai le local match ai mafai la tona draw down the rest of the money eligible like Amrik Samoa. Why not? We need to center the conversation around the medical, the hospital. Levainga o tō mina, malvainga alfalmai, kalkalangoa.
o a mea e mawhaina whai e whalmai. A whapea e te tauna mai a i fō mai. Medical doctors from the States. E whaanga ina i justify ele tupi. I wha lelei atili equipment, wha lelei atili nisi services al whalmai. Ai mawhai e na draw down the rest of the money. That's where we need to go. And that's where the conversation needs to focus. Right now, ai awa ole kia leo kako ai kia i o whasalau I tae au. I au wala e mwhain tatu sosoani ai. And yet, o loa wangalo mai a tātou, o lai ei lea wanoa lea, le whale mai lea. E kaunga kako support inga, ma tatu kalkalango i ai. Dei wa i le board al whale mai. E kalkalangoa ma lātou. Po a mea lai, kaunga whalei atili o a services and need. E mwhai e ngā mai umale tupi, ngā mai lo lea, au ngā ia tatou uma, whai uma ia lea, kari ei mga onga lea tunu ule iai nei, whaptai.
Okay, one more question and then we will go into our lunch break.
Thank you. All right, I'm standing next to the door in case I say something wrong, and I will quickly exit this way. But I want to say hello to the Governor, Honorable. Thank you for being here with the First Lady. And thank you to all of our medical professionals for spending the 2 days over here. With my little knowledge about the healthcare in American Samoa and being part of healthcare operation in American Samoa, there's noted gaps in our healthcare system. If you go to Samoa, you get off the small plane, you ride about a mile, and you start noticing private practice all over Samoa. Compared coming to American Samoa, the only talk is LPJ, and I'm part of LPJ. So just imagine American Samoa having complete free healthcare system, just like other European countries that they enjoy the luxury of going to see the doctor and not having to pay anything. It does not matter what we do as a healthcare system in American Samoa. The bottom line is when the elderly, the children, the people of American Samoa wake up in the morning, they need to go see the doctor. That's all they want to do. See the doctor and provide the highest level of health care for them. They don't have that. They don't wake up in the morning and decide, I have options. I can go see my private doctor, I can go to LPJ, or I can go to public health, depending on the distance where I stay, and I will be able to receive the same level of health care that I need. So one day, if you close your eyes and you kind of imagine the healthcare system united as one in American Samoa. If LPJ is the only healthcare system that is recognized by the federal and everything comes through LPJ, why don't we expand LPJ, the service that's provided by LPJ, so we don't have to pay any match and everything goes under the same CPE that LPJ receives. If we look at our Medicaid plan, most of that is driven through LPJ, the care through LPJ. Now, imagine all of our private sector private practice being part of LPJ as an extension of LPJ. Every healthcare service they provide outside of LPJ becomes a service that's provided by LPJ through the private sector. And those claims will come to LPJ, then Medicaid will pay all of that through LPJ. LPJ will reimburse the private sector. That's kind of like how we can beat the what you call the local match that they're looking for. Any private practice that try to expand in American Samoa, pretty much they have to go through LPJ because of the health care plan. Now, if we kind of take the time and review the American Samoa health care plan, review the American Samoa Medicaid plan, the Medicaid plan should support the American Samoa health care. That way, every service, individual service that's being provided in American Samoa is recognized by the federal, and money will come down to pay for those services. But if we try the private sector, it's very, very hard to have a private practice in American Samoa because LPJ is the key. So another thing we can look at, all of those clinics at public health, they have to come up with a local match. In order to link up with what LPJ has, the luxury that LPJ has got, maybe bring all of those clinics under LPJ. Then, of course, they would be under the same CPE. Something to think about. Now, I'm not sure, I don't have the right answer to this, why American Samoa is the only territory that does not go through the individual enrollment. Just about every state and every territory is now under the individual enrollment, but American Samoa. There must be a good reason for that. So if there's a good reason why we're still under the blanket enrollment, then maybe it's good. The only reason why I felt it's good because of all those non-eligible personnel making American Samoa their home that are not eligible for those care can be eligible for those care. But to beat the local match, I think we all need to come together, review the health care plan in American Samoa, review the what you call the Medicaid plan, then we go from there. There's about 90 to 100 million every year that American Samoa that we cannot pull down because of the local match deal. But the question is, why is LPJ unable to pull down the $90 million drawdown? Maybe because there's a lack of service. We don't have enough healthcare professionals to claim all of that money. How? By having more service. We have a shortage of healthcare personnel. We have a shortage of nurses, shortage of doctors, and they cannot pull down that money because of it goes right back to the healthcare plan for the territory. What type of services are we authorizing to be claimed? So that's my 2 cents. If you don't like it, I apologize. If you like it, and I like it too.
Sorry, I just want to make one comment about the CPE. It's not only the hospital that can use this payment methodology. Technically, DOH CHCs can also use the CPE methodology. Search and rescue, only their EMS services can use the CPE payment methodology. The only problem with the CPE payment methodology is that for about 2 years, you have to do what's called a time study. And this time study determines what are your actual costs it takes to run your services for your provider. And then after that time study is done and CMS approves you to utilize that payment methodology, you can then have the same similar like payment methodology like LBJ Hospital. So technically our public providers, which is basically our government providers, are the best way to draw down these federal dollars. In regards to the private sector, there's a lot of provider enrollment laws that I don't want to get into that will not allow you to draw down the dollars via CPE. They will have to use local match dollars. So when you're thinking about that care plan, Governor, where a lot of it is how can we bolster up our public providers and making them be able to utilize this. But noted, in order for you to utilize the CPE payment methodology, you have to be getting, basically, Medicaid can't be the only payer. So that means public health, so the CHC and EMS services have to be a Medicare provider. So they're going to have to submit that Medicare cost report and get it certified. And once it's certified, it comes to us, and then we know exactly how much we have to pay. So there's a lot of things that we have to take into account of, but I just wanted to provide that extra thing, because LBJ, in order for them to get the CP, they had to do the exact same thing. So that's my only comment. Thank you.
One last comment.
I just want to add to what I was asking about the other percentage. I was hoping somebody would come up with an answer. We do have tools that's paying for that percentage. One time it was the 2%. It was not available to me when my son needed to be referred out, and it didn't help. There's also a 1% that is charged to the corporations on on the businesses. It is there. That is contributed, portion of that 1% goes to the medical care. And then also there's one more. When I was with the TPC, we did hearings for all the foreign businesses that came in, and a lot of them were sponsored. One of the things we discovered is that a lot of the foreign businesses that are here, even though they have a quote unquote a sponsor, when they came in and we asked to make sure they're paying taxes, the sponsor had nothing to do with the business. But here's the thing, there is a law there for all the sponsors that bring in whoever there is and their employees and they're sick. They're responsible to pay for their medical care. And I don't know if that has been utilized. So we do have some laws placed, whereas we care for, I don't know if that's the word ineligible, but there is a way of doing it. And I know Katie was talking about how do we help. We are already helping, but we're not enforcing some of those laws. So that's it, and have a wonderful day, everybody.
Thank you. Okay, well, I don't want to add any more. It's been a long presentation. But we are resilient people. We're innovative. We're intelligent. There's so many great minds in this room today. Let's get out of our own way and work together. And I guess the theme for this presentation today can be, let's just work together to find solutions for our people. Thank you, and enjoy the rest of your summer.
So, may sipatswatsene lava mo le tsai o le finance, ale official Medicaid, so may tsai Wilhelmina sa Lua Tunga Fau, and this lovely presentation. Thank you all so much, audience, for this engagement, and I believe we are taking a whole lot of notes from today in the hopes that we would foster collaborations, more collaborations than we have now with our counterparts, LBJ, DOH, as well as the community. Now, before we move on to our lunch that is already ready right now, can we please have a group photo? Iluma mea, te kuina tato WhatsApp eo anafi, yon tato nga iedea ine tato tau mafutanga o leo uni. Mana au whaaloalo atu, ina fionga kovansini, ia me se foi, tinao le atu nuu, ia mo le tato kwe ngata. Lifetime. Come on, help us out. Let's sing.
Oh,
So much information, so many people, so much to eat. I'm going crazy. Crazy. I'm crazy for feeling so lonely. I'm crazy, crazy for feeling so blue. I knew you'd love me as long as you wanted. Emma, my Oma. And then someday you'd leave me for somebody new. Ese lo leaka, ese lo leaka, ese lo leaka. Why do I let myself worry? Wondering what in the world should I do? Crazy for thinking that my love could hold you. I'm crazy for trying, I'm crazy for crying, and I'm crazy for loving you. Crazy for thinking that my love could hold you. I'm crazy for trying, and I'm crazy for crying, and I'm crazy for loving you. Mele mawal crazy. What kelele I kelele ngofo kelele information. Thank you. You're right.
How about another round of applause for our lovely volunteer singers for this afternoon? Yeah, it's at Sono de Manatu. O ele afai nei le tadinga pelo sua le nei le uli. I would talk to vai the Taimi Mortato panel. Today's panel Hey, it is my honor to introduce our panelists for this evening, this afternoon. Please help me welcome Dr. Audrey Tarr. From the Medicaid office, we have Dr. Annie Flavai. From Department of Health, we have Ipu Ediapo. Representing MPH, we have Leema Hunt. From PCHS, Director Tafai Mumao Chukwuola. Our Executive Advisor for the Health, Bethany Tualupe. And lastly, our lovely Dr. Baitinsa Saluhanken.
Welcome everyone, as Vaitina Sa is making her way up. We just want to thank our panelists today. Look at this powerhouse of women here on the stage. Do we have our chairs? Yes, we need 7 chairs. Thank you. Kaptai Lava. Dr. Annie, we can't do this without you. For those who were here yesterday, we had a great panel. It was our clinical panel. We had a lot of perspectives from clinicians here on island from LBJ, DOH, Medicist, as well as Medicaid. Today really is a continuation of that, really for our community. So this is more of a community focus. We have community members. All of our sisters here up on the panel work in the community. Some have a clinical background and some do not, but I still think it's worth hearing what they have to say, don't you? Okay, good. So our opening question, like I said, this is an extension of yesterday. Our opening question, actually, can we just pass the mic, and if you could just introduce yourself briefly. Let's start with Dr. Tarr. Dr. Tarr, you don't. Just a brief introduction.
Talofa, my name is Vaitina Salatu Manuana Momo Oil Tuitonga. Aile o Salu Salu Atota. Salu Salu Malo Melele Mulatunu. Hanken Finau. I am very happy to be here. I'm telling you, this is just so awesome and exhaustive. Thank you.
Hey, I told Deputy I think I would have preferred the karaoke over the panel, but anyhow, malo soifua, lo ingoa Bethany Toilupe, lo avea mafafautua, ile ofisa kovana, ile soifu maloloina faftailava.
I think Medicaid Summit this year just elevated lunch at a whole different level. Thank you for the idea. So Tafai Mamau Tuatupuola, I am the State Director for the Pacific Center in Human Security. Thank you.
Talofa everyone, my name is Leema Hunt. I'm currently paid under Tafa's program, under USAID. And so I am feeling a little intimidated because of this powerhouse of women that are here. Just to give a little background, because I'm sure they've established themselves in the community, I have my master's in public health, which is what MPH stands for. I've worked for the Centers for Disease Control and Prevention for 4 years during the COVID-19 period, and had the opportunity to serve the Department of Health under Director Motusal Nua's leadership for almost 12 years. So I do have extensive knowledge in public health, not as much as these lovely women here, but I'm very, very honored and privileged to be sitting with these women, and thank you for including me in Medicaid Summit.
Good afternoon, everyone. My name is Ipu Eliapo Nutoa. I work for the Department of Health. I am assigned a few programs there that cater to women and children. I am in charge of the Rheumatic Heart Disease Control and Prevention Program, as well as the Children and Youth with Special Healthcare Needs. That serve kids with special healthcare needs from 0 to 21 years old. And I also lead the Leo O'Ainga Health Information Center that supports families of children with special healthcare needs.
Good afternoon. My name is Dr. Annie Fuavai. I'm the Clinical Medical Director for Medicaid.
And Dr. Audrey Tar, OBGYN and past medical missionary on the island and working with some future preventive women's health care projects on the island. You hold on.
No, you hold on for that.
Hold on.
Okay, well, thank you, ladies, for participating in our panel. Take a deep breath. And I want you as the audience to make sure you are thinking about questions you can ask these lovely ladies while they're up here. The continuation of our conversation from yesterday in terms of prevention, the first and opening question we have is, where does prevention really happen in the community or in our community? And where are we missing opportunities to reach people earlier? Where does prevention really happen in our community? And where are we missing opportunities to reach people earlier? Whoever has a mic, go for it.
I'll start. I'm not a medical doctor, but I have 5 children, 5 grandchildren, and 3 great-grandchildren. Don't ask me about my age. Prevention, to me, as a mom, grandma, great-grandma, starts at home. The home is the center for all of the things that we face in the world. It starts from home in terms of the practices, especially the mother, who takes a leading role in teaching the children at home. The habits, what they eat, when they sleep, how to play, how to be kind, how to talk. The mother has the leading role, and the father strengthens those same values. So for me, as a member of this community, having grown outside of Samoa, but had my children and family here for years, the key to prevention is the family. That's where it starts.
Thank you.
I'd just like to add on to what Dr. Hunkin Finau said, and I think this is also along the same lines of what Dr. Annie had shared yesterday, which I think is very profound, and that is utilizing the AINGA. I think care coordination happens first and foremost in the family. When mom and dad decide what appointments are they going to make that day, are their kids meeting their vaccination schedule? So those conversations are happening first and foremost in the family. And a lot of times we see that in the hospitals and the clinics, they're taking the lead on that. But I think taking it out to the community, to the families, and ensuring that our systems work around that AINGA model would be ideal. Thank you.
I agree with Dr. Vaitinasa and Bethany. I really think that's where your return of investment comes from. You funnel the resources in the home, in the community. If that's your preventive measure before you get to LBJ, that's where you want to invest. You want to invest preventive services within the home. I think time has changed. There was a lot of talk earlier about imagine. No, we need to reimagine what does prevention really look like in our household? We don't know the financial hardship of each home. We have single dad, 2 daughters with autism, a single dad with 2 sons with autism. We have a single mom, primary caregiver for mom, her mom. And we don't know these financial hardships. That's the reality. So when we talk about selecting bongos, selecting signee, we also need to imagine what does that financial situation look like in a home. It's not your standard home. Time has changed. We have empty nesters. Children going, they don't come back. Parents are taking care of themselves. We need to reimagine what does preventive care looks like in the next 5 years. I just returned back on Thursday, and I know in the past we always talk about all the wheelchairs, all the wheelchair users when we arrive in Hawaii and when we board Hawaii. It's because we invest a lot in the medical referrals. That's the honest truth. And I agree with that. But what are we doing to reimagine what does preventive care looks like? Thank you.
Thank you.
Yes to what our 3 lovely women said. And in addition to that, I think it's important to take into account the social ecological model. And I'm speaking from a public health perspective. In the social ecological model, it talks about how an individual is influenced by various levels. You know, the individual themselves makes healthy choices. So there are prevention efforts that can happen on the individual level. Then there's also the intrapersonal level, which they just spoke to, family relationships, immediate family relationships, and many people have alluded to that as well. There can also be prevention efforts there. There's also the community level, interaction with churches, how that directly affects a person's health, and then also at a policy level. I think there can be prevention efforts at each level. And I'm grateful for the opportunity to witness your local actors who play a significant role in trying to influence health at those levels. And I would like to see more of people like Erica and Ashley doing Zumba on island, making exercise available for them. You have also Katie McCutcheon, who has multiple nonprofit, multiple programs that are designed to help kids at school. You know, a lot of their time is spent outside of the home. So I think prevention efforts has a lot to do with supporting existing programs. And there are a lot of wonderful existing programs locally. If I could speak to perhaps the individual level, I have had the opportunity to work on 2 committees where we were looking at the health of adults in American Samoa when it comes to non-communicable diseases. We did this in 2017, and then we did this again in 2023. One of the things that we saw in those surveys is that nearly 80% of our adults are not consuming the recommended amount of servings of fruit and vegetables per day. Now, if you look at the individual levels, how family influences that, how our community, including churches, influences that, everyone plays a role. A lot of the times we look at this where it's just government that has to act, but it's not just government. It's multiple people that have to do this. And I wanted to also highlight the American Samoa Cancer Coalition when they researched the feasibility of healthy beverages policies in American Samoa, where churches are, during big events, are passing out water and new versus soda and drink. We're not doing enough of that. So going back to a lot of the comments that were made, it does fall on us individually, our families. It's a complex question that I feel like everyone has a responsibility for. I also wanted to share additionally, in these surveys, it said that 15% of our people reported fair or poor health in 2023. The rest of our people said we're okay. 15%. Yet, majority of our adults are overweight and are suffering from either hypertension or diabetes. So there's a gap between what we're reporting. Obviously, our adults are perceiving ourselves as fair or poor health, and only 15% of our people are perceiving ourselves as fair or poor health. The rest feel like it's okay. So that also brings to the point when it comes to prevention, we can improve in health literacy. One of the things that the American Samoa Cancer Coalition frequently has told me when working in communications is that our information that we pass out to the public is still too difficult to understand. So we can improve in health literacy. We can improve in supporting existing programs that are working really hard to strengthen the health of our community, and we can improve in other areas, but I'll stop there for prevention. Thank you.
Thank you for that. I think we found our next year's keynote speaker. That was great information, Leema.
Thank you, Director Luisa, for the question. I'm going to try and answer this from my perspective as a manager for the Rheumatic Heart Disease Program. I think I echo from the previous ladies that yes, prevention is at an individual level. You and I are both responsible for prevention, all of us. But I like the way that the World Heart Federation had dissected the way we manage rheumatic heart disease, and it is at every single level of care, starting from primordial level to primary to secondary to tertiary. And when I say that, I mean from even before a child or a person acquires strep infection. Rheumatic heart disease is known in countries that are overcrowded, poverty is high, access to care is low, and so that kind of, says American Samoa in there, and we have a very high rate of children found with heart valve damage because of strep infection. And so if we miss that level, and we're not doing a great job at preventing, not having good systems of, good water, drinking water, clean schools, and homes that have sufficient room for people to live in and avoid crowdedness, then we get to primary level. That's why you hear us coming out into the schools and screening kids and putting an echo machine on them and trying to see if they had ever had a sore throat and they were never taken to a doctor, does this kid running around having a leaky valve? And we can find those kids and then get them the care that they need. And that's where secondary prevention comes in, where we route them to the clinics and make sure that they get the medication that they need to assure that their hearts stay healthy, even if it's leaking. And if it gets to the point where parents are not bringing them to the clinic consistently to get this medication, then we move on to tertiary prevention, which means that they will have to go get surgery, but after surgery, is our system of care able to take care of these kids when they come back to American Samoa? And that means making sure they are tested every month, or our hospital system has medication in supply that these kids can have access to. Because if not, these families are not going to return home, or this child will have had surgery for no reason and they die early. And that is the honest truth. So the reason why I'm bringing this up is because prevention happens at every level. Until someone dies, then there's no more space or reason to do prevention. But right now, while we are all still breathing and walking this earth, we can do prevention. Thank you.
Thank you. Dr. Annie.
Tai mole avanoa. Salo la fasa moa tu o le tele lava o saunoanga fo'i wa mawai atu. Ia o le ia lava e tasi. E pi tele lo mana tu i le amatanga mai o whaatanoanga i le tina ia salu. Ioe e amata mai tonu a inga. Ia tatou mauti noa fo'i. O le taimi lava e alu e le tamaititi le aonga. Pea ngai fo'i le nā tamaititi malu i tau o le nei o langa. Ia ona o whaososonga fo'i a wō, ma mea whaapena. So, e le mapu, e pole a lava fo'i le taumawhai o tātou mātua i a whaasao meise i a mea tau sami. Ia e ona o le mele ta o le peer pressure. Ia e manu mahaloa le tele o taimi. O le mea taimi tonu lava nā i lo utal tonunga i tātou malo. O lo ia i uma pulo kalama. There's youth and women. A matutu atu tamaiti e ele Samoan Affairs e iai pule nuu. Sau i tātou e kalesia a tātou tanga i tātou motu meo le falsa o lo iai ia tu o pulo kalama whaife au tu pulanga talavou. So, i lo umanatu to atasi. O lo misi lava e tātou le avanoa le nā tātou te o mai whaatasi ai. Whai se whainga. Ia whapena na muli muli tae ai a tātou whanau. O tele na wā tātou ploka lama. Ao le whaalave lave. O le ngā lulu e whaatasi. E alu lava le ploka lama la tō. Ia e misi atu ai fo ima. Nisi o alom whanau. O lo whea ngai mwhaafita auri. Pei o le tino puta. Ia mau ai le suka toto maua lunga. Mai whatu. Le anga fonga. Ia ma mea whaapena. O le tātou autu o le tātou summit. Ia malu pui puia. Ia e leo se ngā luenga na o le Medicaid. Ia o le ngā luenga whai whaatasi a tātou. Male malo lo tele tātou polokalama. Ia malo whaalo a lava whaatai.
Whaatai.
So my apologies if I repeat something that Dr. Annie has just said. But so I'm going to look at this from a clinical perspective. And when we do research on trying to understand populations and prevention of disease, we always place an element in there of the social determinants of health. We have to acknowledge that health is more than a visit to the doctor or the tests that we do, that there are factors that have been really well addressed by the panel that are a critical component of prevention, right? It starts long before you go into the doctor and get the test. But we also acknowledge from a completely clinical perspective that if we don't make it easy to come in and get the test, if we don't acknowledge all of the reasons about why someone might not come to the doctor, and those are different for each person, right? It could be transportation. It could be the distance to the clinic. It could be the knowledge and understanding about why they want to go to the clinic. It could be a fear or a dislike of the clinic, right? There's all kinds of factors that keep somebody from accessing that care. And for the question about where are we missing it and how do we provide it, we address those reasons, right? If it's an issue of transportation, we address transportation. If it's an issue of location, we do what we can to address location. right? We want to make it easy for patients to choose prevention, right? It should be the easy thing to do, not the hard thing to do to get the needed tests, right? And we need to acknowledge sometimes the main reason it's not done is lack of knowledge that it even needs to happen, right? And so clinically, the systems in the world that succeed best at healthy prevention invest heavily in the social determinants of health, right? They address their challenges socially that make it difficult to remain healthy, in addition to all of the medical tests that we typically think of.
Thank you, Dr. Tar. You answered my second question about what keeps people from seeking care earlier. And you mentioned that through the social determinants of health. And I asked that question yesterday, and I got more of a clinical perspective, but I'd love to hear from the community, what measures are you taking to exercise prevention or to implement preventive care in your lives and in your homes?
I always hear the announcements from the Department of, I don't know which department, the health, I think, and they actually read out the alphabet of your last name to pick up your social services, to pick up your food stamp. They do this every month. A, E, ia o le aso nei o mai o tau, I, O, ia o le aso nei o mai o tau. Why don't we have something like that? La me le whai ese tato prokalama whapena. Whai nu. Ta o mai ngō a inga. O asoi. Someone not custom, but practice is that, say, longa wa mai ta mai titi abelor whal mai. We don't do like a quarterly. Yeah, let's go check. Let's go see the dentist. Even though there's nothing wrong with them, make it a habit to take the children to the dentist. Make it a habit to just go. Don't wait until the child is completely infected. Rush lola ia palmaiahu. Ia wa mawal lungal koko ele lo lai mawal high blood pressure. So my thought about this is, why don't we do something as a community? If one department can do that and get people to come pick up their, SNAP, Marisime, why don't we do something like, excuse me, I'm ignorant about that. Why don't we do something like that as a coordinated? We have to remember, and I'm glad that we're all in the same tune. It starts with the home. And I want to call this Ana. Ainga, nu'u, atunu'u. It starts in the family. The parents have to take more responsibility. And if we have to remind them every month to pick up their checks, remind them. Have you taken your children to do this? It's open now. Go and take your children and check. Thank you.
Yeah. Oni lava le saunoanga, Dr. Hunkin. And I just wanted to add, in the previous program that I worked for, Sayay Sitina, there's a mom from the village of Falinu. There's this child that we kept trying to come in for a follow-up appointment, didn't pass their initial screening at the hospital. Few like numbers, calling, trying to find out if there's a number with the neighbors, just trying to make sure that we screen this baby, because then it would be considered a loss to follow up a child. But our goal is to screen every baby in the territory. Couldn't get a hold of mom, but finally, when we did, mom said, I work at the canneries. I don't have time. I'm a single mom. This is my child, and I have to be able to put food on the table. So prioritizing, my baby looks fine. When the door closes, my baby startles, so I think her hearing is just fine. But for her, she, as Dr. Eminoni had mentioned yesterday, it's a lot of priorities. People have different priorities, and when it's coming to do a follow-up appointment to which they have to catch the bus in the hot sun versus putting food on the table, you know, they're gonna definitely choose putting food on the table to feed their families. I think the 2023 census had put that those in American Samoa, over 54% make under $28,000. And so for a lot of families, they struggle to be able to make ends meet. And so that's something that we definitely have to consider.
And so I'm gonna tether off of Bethany's comment about within the home and coming from a caregiver experience. I think about what if we get the caregivers, who is the only one in the home to care for their family member, nobody else, empty nesters. None of their children are here. You have that one person taking care of that individual. But mind you, we're not trained because we didn't go to school to be caregivers. We went and got work experience, a whole different space. But we're trying to learn as we go to take care of mom or dad, but not trained. Then we wonder, where is this bed sore coming from? We don't have enough money to take care or even buy diapers, right? We don't have enough bandages or medical supply to take care of our family member. The person ends up going into the hospital, gets admitted in, another cost. 2 weeks, 3 weeks till they're healed, go back. Caregiver goes back to the caregiver who is not trained, by the way, and this goes back again. How much are we investing in the home? If we want to lessen the cost of admission rate, we need to invest more in the home. How are we training caregivers? How are we providing more nutritional counseling within the home? What I notice is that if a person has diabetes and they're asked to watch their diet, the one person, not the whole family is changing their diet, that one person is being asked to change their diet. In the meantime, everybody at the table is enjoying a good Samoan meal every Sunday, and that one person has to sit at the corner and a lot of temptation surfaces on the table. So where's that support? How are we engaging everybody at the table to support this one person? So if we're talking about prevention, how are we investing again within the home? Thank you.
I know that there's multiple ways to answer this question. I mean, and there's more than one right answer. One of the personal experiences that I do want to draw upon is a collaboration between alumni of a university, Brigham Young University, Department of Health program, IPU's program, which is rheumatic heart disease prevention, and I believe it was also with the help of ACE, and Director, feel free to correct me, but one of the, and feel free to add on, Ipu, I'm sorry. Just my perspective of this was just, this was an excellent collaboration that helped to address social determinants of health. You had Brigham Young University that was there to translate material and to also provide additional support with regards to providing clinical care. You also had members of the community that were proactively looking for ways to bring these clinicians on island to help provide care. And at the same time, you had the Department of Health that was the hub for providing these services. And it was also a collaboration with the Church of Jesus Christ of Latter-day Saints too. one of the biggest highlights for me personally is that this wasn't just a one department effort. It was a systematic, a system level effort that helped to make screening more accessible to families, helped to educate students at schools as well. So when it comes to prevention, and I was speaking to Director of Agriculture about this as well, is we need to look at it from a systems perspective. What resources don't I have that perhaps your program has that we can collaborate on to make access to care easier? Additionally, I believe Dr. Early spoke heavily on this yesterday about the need for health education. According to the survey in 2023, 40% of our people of adults have not gone in to get their annual medical exam, meaning they haven't gone in once to get a checkup. And that's true for multiple reasons. And our women here have explained why. Transportation was difficult. Bills are a priority, not stopping at the hospital. Health is not at the top of our priority list. So I think one of the ways that we can help to make prevention easier is definitely through collaboration. That's one aspect. Another personal experience that isn't mine that I do want to share is, I believe, Pastor Yasepi from Fongtongo. You know, he and his lovely wife have made their health journey a priority. And one of the personal experiences that Tina had shared was that their congregation would provide food for them after every event. And, you know, it's culturally, you need to accept it. But they made the hard decision to not accept it, to the point where the congregation understood that food all the time for them is not part of their goal. So finding champions in our churches too help to set that example. And many of our churches already have a health code. Your Seventh-day Adventist has a very beautiful health code that yes, and the Church of Jesus Christ of Latter-day Saints, no bias, also has a beautiful health code that we need to be brave enough to prioritize over acceptance of food culture. I don't know how many times we go to an event and people are just like, oh, the event wasn't all that because the food wasn't all that. You know, that's the mindset that we have. Anyway, long story short, social determinants of health, yes. Our communities, yes, and many collaborations that we can build upon.
Thank you, Emma. We're going to move on to Ipu and then Dr. Annie and Dr. Tar, but because of time, we're going to end after this question and open up to the floor.
Right.
Okay.
Director, can you remind me again what we're talking about? Because there was just so many answers.
No, we were talking about measures that you're taking in your own life to practice prevention in your communities and in your home.
I think everybody has already mentioned all the things we're continually doing.
Yeah.
It's just so very important that we reevaluate ourselves every time. We have to stay flexible. If we want prevention to work, we have to stay flexible because we have to change with time. Yeah. And people are, you know, people change. And if we remain stagnant in the way we do things, then the preventions that we may have done 10 years ago may not necessarily work right now for the community that we are trying to promote prevention in. So that's one of the key things. Stay flexible and keep learning and keep adjusting to the changes that come.
I agree with that wholeheartedly. I think oftentimes we say we hear the same thing over and over, but that's how we make change. We keep talking about it. We keep putting it out there and having these conversations, because once we stop having these conversations, that's when we're in big trouble. Dr. Annie, do you have anything to add?
No, I have no additional comments. I think these beautiful ladies have said it all. Okay. Thank you.
So I'll just answer this with an example of some work on the island about how we would do this. So I'll answer it first from a personal perspective and then from that work. So if I want to make a change at home, I have to really ask myself, why is this important enough to me yet? Right? Like, I can't make every change I want to all at once. I can't make every change I want to in my home all at once. But I'm going to focus on what is most important and why. Right? So we decide, what is my why? I want to be healthy enough to run around with my grandchildren and enjoy, the next family reunion. If that's it, then we ask the questions back. But we really have to get at the why and acknowledge we won't change until we're honest about what's most important in our life. And then sometimes we need outside help from programs to recognize, if you really want that, you need to do this, right? Like, if you really want to be healthy enough to run with your grandchildren, you're not getting enough exercise and you need to change some weight, if that's really your goal. And so I think asking the why personally is really important. But now I'll put on a different hat and talk about clinically. So if I observe a problem in the area of work I do, my approach in the community and where it is I start by asking what's happening with the patients. I observe the challenges that they are experiencing, and then I try and answer it from that perspective. So when I was here on the island and I was caring for women, and my goal was to get them their routine screening, right? My goal was to make sure they got cervical cancer screening, breast cancer screening, uterine cancer screening, colon cancer screening, right? And that's not high on any of their list of why, right? Like, if I just asked you what's most important to you, none of you are raising your hand and saying it's my pap smear, right? That's kind of on the list, you should do it, but that's not high on your why. So my job, and as a clinician, is to make sure that I help that fit in as quickly as possible, because I know how important it is, right? But I know it's not top on any of your lists, and I am under no illusion that I'm going to place it there, right? Like, for a variety of reasons. But if I want to make the care, I need to understand why you don't come in, right? And so in the process of doing that, I heard many things while I was here for that year, all kinds of things. So then I come back to it with that information and I say, what can we do to help? And is it okay if I just make a quick pitch for the, so I was approached by the Cancer Coalition saying, we really want to focus on women's health, and we want to focus on that, on prevention on women's health, because we understand the woman is directing the rest of the health in the family. If you want a happy home, like happy wife, happy life, right? If you want a happy home, if you want the family to function well, it's key that the woman in that home that's providing much of the care is healthy and well. So our goal is women's preventive health. How can you help? And I take the perspective of what I had for the years that I were here, and I said, this is key, right? I know these things are a problem. I know from the experience there that it's challenging to come in without an appointment time, that appointment times need to be flexible, that transportation is difficult, that they want privacy, that this is already an uncomfortable exam, right? I know all of those factors. So we've created a clinic that will be opening in the middle of June to try and augment what DOH and LBJ are doing, right? They're overloaded, and their why too is hard. They know pap smears are important, they know all of these other things are important, but they're dealing with so many other problems. How do we help? So we're starting a clinic in the middle of June. It's called Tasi Leola, and I just said it wrong, so say it right for me. Tasi Leola,
Yeah.
Did I do okay? I had to get help with my Samoan pronunciation. and so our goal is to make the collection of all of those things, all the things no one wants to do, right? Their pap smear, their other screening, to make that collection as easy as possible. So we give women all the options about how that's collected. They can have a provider collect it, they can have the nurse collect it, they could collect it themselves. right? We think outside the box and we say, what's the easiest way? They can have their partner collect the specimen if they need to. And then we take it the next step and we say, okay, we know it's hard for women to get there. What if we could make it so we went into the village with all of our supplies? We went there, we handed it to them, the woman went back to her home with or without the nurse, her choice, and she collected all of her samples and we picked it up and we took it back to the clinic. And so I think that's an example of this in application. I'm super excited about the clinic. It's all built on a nurse model, right? So we know that resources are a challenge on the island, right? So we will have nurses help patients do all the tests they need to, collect them. If the answer comes back concerning, right, if the test comes back positive, if it says there might be a problem, then we will have providers that rotate on island every 3 months, and the nurses will work on figuring out how to help that patient that we know now has a high risk. Right now it's not just maybe they need help, but they definitely need help. We figure out how to get them into clinic because now we can't just do it in the village, right? Now we got to get them into clinic. And we work through all those social determinants of health that are challenging, right? But I own that my perspective as an OBGYN about what's important isn't yours, right? I own that I'm going to have to figure out how to bring this to you and fit it into the middle of your life because your pap smear is never going to be the top item on your priority. Even though I know it's important, right, I have to take down all of those barriers. So again, I'm super excited about the clinic and what it can do. And again, it's that taking the principles we know, thinking outside the box and saying, with the challenges here, how do we re-deliver care? How do we re-deliver education? How do we re-deliver knowledge? How do we re-deliver food? How do we re-deliver choices? How do we make it easier to do the right thing? And it's one step at a time like that, that if all organizations do that, if I do it with my hat as a gynecologist, if, you know, Leema does it with her hat of, you know, public health and where those changes need to be, then in a few years, you actually have results because different people are working on different pieces of the puzzle.
That's exciting. Thank you so much for sharing that news, that we'll have some more services provided to women of this community. You know, what was alarming for me was hearing 15% reported poor health in 2023. I can imagine if that survey was taken again, what those numbers would look like. But I think it's about, they don't know what they don't know, right? And I want to know, by a raise of hands, how many of you have had your annual health exam in the last 10 years? Raise of hand. Keep your hands raised. Last 10 years. Last 5 years. Last 3 years. Oh, that's awesome. In the last year. Okay, we only have a few. See, you have some consistency back there. But we won't know what we don't know, right? The reason why we go to get these annual exams is to help us understand how our bodies are functioning and what we need to do to take better care of them. I think that's where what you heard today is hopefully inspiring and encouraging you to get out there and get your annual exam. And we're coming to the table making it much easier with the new clinic coming to our island in June. So now we're gonna just take a few minutes. My team has a couple more presentations, and so does State Director Tafa, that we need to get through. But I wanna open the floor. If you have a burning question for these ladies up here, please raise your hand and the mic will be brought to you. Back here.
I don't have a question, but I need to share some comments. I'm not a medical expert, I'm a doctor of common sense. I'd like to acknowledge Tafa's office and Ipu's office for allowing Salmon Study Institute to translate its flyers or booklets that go out to the community. Any other agency who use Google to translate in Samoan, please don't do it, because the context will change. Thank you, because we get extra money from it. Secondly, I'm a board member of the Community Health Center, as I alluded earlier. We're working with the DOH leadership to get those nurses, those services out again in the villages. Do not expect people to come in because they will never do. The external factors that stop them, as you have alluded to. So we're working very hard with the DOH leadership. Unfortunately, I don't see any of them here, except the rep there, the director, to take those services back to different sectors of the island. Lastly, from experience, from observation, my experience being involved in a lot of organizations, not only the government, but private organizations, I always pose these questions with grants, agencies with grants. They apply for the grants for the same purpose, but they want to compete against the other agencies that are doing the same work. They duplicate the work, and they are so possessive about their own funds. But they're competing for one person just because of the data. And I always voiced this about 20 years ago. Why can't all agencies come together and cost share, deliver all the services, defeat the same purpose, for the same purpose? For example, if public health goes out, take a nutritionist with them, take the Department of Agriculture with them. These are what you need to grow. Dr. Fuavai said it very well this morning. Working together, collectively, do not compete because of the grant that you're given, because you're competing for one person. If I am involved in a lot of other grants, you're counting me as one of the many. We have to work together and do not compete because of funding purposes in order for that missing opportunities. Reach out. Let's reach out to the community and people will understand who we are. There's no sense of us going on TV, doing it on the radio. People listen. Pacific people learn better. We should. Thank you.
Thank you. Any questions out there for our panelists? Looks like we need to, we have a question?
Thank you. I was interested to know the source of the studies that Emma was referring to, the 2017 and 2023.
Your source of service studies?
Like what organization did
This was directly through the Department of Health in collaboration with regional partners. So I believe the 2017 report is available through the Department of Health, and the 2023 report should be available soon. And I'm only speaking to it because I was directly involved with a few others that are in the room in the collection of the data. So long story short, the Department of Health.
Thank you. Data is very important to all of us in American Samoa, and I appreciate that. Thank you.
Thank you. Any questions, ladies, women? Do you have any? You have a question up here?
Sorry, this is for Dr. Tar. For the clinic, will there be services for pregnant women?
Yeah, so we're starting where we identified the biggest gap, which is that preventive care, right? That we talked about that a little bit yesterday. It's really hard to walk upstream when all you're doing is saving people downstream. And so to take that burden off, we're adding that to begin with. But the goal is to keep filling in gaps, right? So in the beginning, no, that'll be the short answer. We won't be doing any pregnancy care, but it will be looking and saying, okay, where else is DOH and LBJ struggling? How else can we augment the burden that they carry? Where else would resources have the biggest impact, right? And so some of it's looking at it and saying, okay, limited resources, we all wish we could have everything, but we can't. And so that next question is like to be determined, but right now on our Vision list for the next step will be addressing primarily some of the prime gynecology, so not obstetrics problems that women experience on the island, so taking on the bleeding challenges, some of those other things that if treated earlier would prevent a lot of health impact. And will obstetrics ever be in there? I mean, again, that will evolve as the community needs to, and as our partners tell us where they continue to need help.
Thank you for that.
Okay, we are going to move on. No more questions. But in closing, I just want some final remarks from each of you. I would say less than a minute, please. But what is one thing we should start doing now to build a more health resilient American Samoa? Just bringing it all around to prevention. So, Salu?
I'm going to break the rule a little bit. I have an announcement, very important announcement, that's also, it's all related to everything that we're doing. Our Retirement Fund Membership Association is meeting this Saturday, 9 o'clock at Vibes. We invite all of you to come. There's so much to discuss. At any rate, with regards to our discussion today in terms of health, and I know that I've said the word family, ainga, so often because that's the heart of the whole thing. We need to coordinate. All the agencies need to coordinate. And we don't wait for people to come to the clinic. We go to them. We go to them. Media, however way that we're going to get to them, get to them. In closing, I'd like to say that these few words come to mind when I think about all of us involved. Those that are doing a great job with our public health. I'm so glad that Motusa is here, who spearheaded the idea of those district clinic, wonderful idea. We need to expand that a little bit more, okay? We have clinics for Ainga that come into that. But I think the word that we can use, or the thought that we can use to bring us all together, to enlist family, village, agency, government. Enlist, educate. We need to educate. The average education level of American Samoa is still a high school and a little bit over. The average income is a little over $20,000 a year. And yet our obesity rate is close to 90%. Everything just falls in place. We need to educate, enlist, educate, compensate. Now I want to say the word about compensate. When I drive around our community, these areas where they have fantastic and humongous bingos, every seat is occupied on bingo night. If every seat was occupied, waiting to get together as a community to work out our health problems, we would get compensated emotionally, physically, mentally, and spiritually. Thank
you.
I'm going to add another E, because she said enlist and educate. I'm going to say engage. Engage leaders across government, but also engage our families, engage our church leaders, engage our communities. I think Governor Pula has shared this time and again with our Health and Human Services cabinet members by saying, get out to the villages. Get out to the villages. And so I know Department of Health has started a pilot program out in Afono. It's called Nu'u Manuia, or Ainga Manuia. And then they are going to use that to bring it, put it to scale and really hit upon our, what's considered our urban areas, our very dense populated areas like Tualautsa County. So I think that'll be a great way to engage on all of these different levels that we've talked about. And I just want to share that I think it's important not just to, we talk about collaboration and working together, but at the end of the day, a lot of folks are territorial about data. A lot of folks are territorial about, because for them, it's like, we've done the work to collect this data, and what can we get from you if we're gonna share this data? So if we're really gonna talk about collaboration, I think we have to bring down those walls and be able to build an environment where we can really trust each other, because at the end of the day, it's about helping our people and giving our people the quality of life that they deserve. Thank you.
Absolutely. Thank you.
I think spaces such as this, opening it up to the public, hearing from the public, I really believe that if we keep listening to what the public is saying and think about it in a way that we're not taking it personal, but taking it in a way that we're going to be problem solvers. When we come to spaces like this, we need to come with the problem-solving thinking on how we're going to walk away and solve the issues in these conversations. Second, I really believe ASCC, I work here, so please don't. ASCC, we need to engage health conversation like this.
Yeah.
Take it into the classroom. We need to talk about the reality of health in our territory. Let the students be innovative and be problem solvers. I like the idea how earlier this month we had Dr. Early come and have a brown bag event here at ASCC. I was talking about diabetes to ASCC students. So how can we keep having these community conversations to the general public? We need to get them engaged with current events of what's happening, change the way we think, system think, problem solve. Thank you.
Thank you. In addition to what was said, I'm going to quote the Obesity Awakening Movement, which is a nonprofit organization locally. We need to change the way we think about food. The surveys that we put out in 2017 and 2023, while they don't tell the whole story, there is a strong indication that our food consumption has not changed. 80% of our people continue to not eat the recommended amount of food servings of fruits and vegetables. And that has not changed over a span of years. And I do once again want to highlight the Department of Agriculture as well as Samoa food security. You know, in speaking with them this week, one of the things we talked about is that over 90% of our food is imported. So in light of what's happening in Iran and in the US, when fuel costs go up and when shipping affects the price of our food, we have not changed the way we think about food at church, at home. And what I would love to see is simple ways to change that. Supporting a farmer, giving your child a healthy snack at school versus bongos and chips. That's just one way. The last thing that I do want to talk about is this isn't the first time that I've heard about nurses going out into the community. Yes, while I do agree with that, in 2015, Director Nua as well as Director Sandra King Young put out the state innovation model through Medicaid, in which this document said that in 2015, there were 65 healthcare providers to take care of a population of 55,000 people. The ratio to that does not make sense. And I believe that the ratio has not changed. Healthcare provider to the amount of people in American Samoa is still way out of balance. So what does that say to us as a community? It's not just the healthcare providers that we need to rely on. Each person here has a skill that you can emphasize in the community that will directly affect the health of the people around you. Utilize those skills and change the way you think about food, including me. Thank you.
Thank you. 1 minute, please.
Yeah, more why it's wale evaluate, and when I say evaluate, I mean self-evaluate. Ole avea yo o matai ele mafai ona manuia nga luenga leo te faia ina ia soifua malolo ina ifa na ainga pea ole fai ma uno foi lalo toe vavaai i le whainga o ngā luenga po le meo le lei pele ai. Wa a fuona le le ia o whitwhiri ngā le whaia tui taita. Ma o te iloa e le mwhai e tātou na control ma whau ma winga ma ngā o tangata lau tele. Ai ma whaia e oe na control ai oe ma o a mea fua mai ono launga wenga. So e ta awa I o me leo lo no fuma to evaluate o aluenga lo fai po o meo ye ni a fianga le lei po o meo lo o au siona e a apa tu I tangata uma lo o tau ona manuia I alanga au nanga ye te whaia pele ai. A wha pe e te tawana e suinga, e te tawana e matala lo ma fau e whai suinga na pe no whai atu te mi o atua nai. A wha pe la e whai ala unga luenga I le maasani e sau mai ei se fulu lua se fulu tau tanga tanu ai. Ia e te iloa e le o se unga le lei fo I le te leo wa ai se outcome le lei. Ai a wha pe te whai ma e to e sa le whao wa ai tūlanga e taona sui na ia mawhai ona maua uma I tangata uma ia le wha manuianga le te nau I ai ia o te talitonu e se lumana I manuia mo tato atunu ia o le whapopona nei ai wauri whaatai.
Paua sina whaapopo le tātou o e whaia tātou whaatanoanga I tua I nuku. Outreach. Ia mele le tātou ngā lue whaatasi wae. I lo mawhawhau I ei tele o mai e refer mai Medicaid. Ia o tangata I tua o nuku. E le I o I ai le whaatanoanga nei le tā ua o le inuina o whala au o le mea tau sami, whamalo sino, Talo le sile au wala I sosoani ai o tātou tangata. Awa e le o atu I ai le whatanoanga nei no whalo alau.
So I'll just echo quickly what Leanna said. I will keep under the minute. I can't tell you the number of women that came in and told me that when they left the island and they were away, that they easily lost weight because it was much easier to eat. So that's a telling factor, that simply by walking away from the island for a time, being with family elsewhere, they lost weight because the food choices were easier. And I can echo that. It's hard for my husband and I on the island to eat the way we would choose to eat at home. So that's just a pick. And then mine is just quick. I will leave the handouts for the clinic. This is what we want to do in the next year at the back. I only grabbed one of the Samoan. I thought I was grabbing a pack of both. So I'm sorry, only one is in Samoan and the rest are in English, but we have lots in Samoan.
Thank you. Thank you for the plug on Tasi Leola and also the retirement meeting happening this Saturday. You know, we have to use the platforms we have, right? So what we heard today is exactly where prevention lives. Not just in clinics, but in our homes, in our families, our churches, and everyday choices. And the reality is, most of what drives our health happens outside of the healthcare system. It's how we live, what we have access to, and the support around us. So if we're serious about prevention, we have to meet people where they are, and not just okay them on how they're supposed to live their life. We have to meet them where they are and build a system that supports them earlier, not just when it's already too late. So thank you all for sharing your wonderful stories. This is what will help us to move forward. Thank you.
Testing. Ladies and gentlemen, please help me welcome Program Integrity Division Head, Ms. Matilda Kvzk, for the Program Integrity presentation.
Of course, they have to put me after lunch. I'm seeing a lot of people have been sitting so long. Please stand up, stretch out, please stretch. Because there's another presentation after me, so get all the stretching you can right now. Okay. Now that everyone's nice and loose, you can now sit back down. Okay, greetings and talofa. As mentioned before, my name is Matilda Kvzk. I am the Program Integrity Division Head, overseeing our Medicaid Program Integrity Division. We are a mighty team of two, which includes myself and our newest addition to the Program Integrity team, Agnes Tilo Lamositele, who is doing an amazing job with our mental break sessions through the summit. Give her a round of applause. This is why she's not presenting with me. So, basically, I will be presenting on our program integrity work we do at Medicaid. Before I talk about program integrity, I would like to go back to what the Medicaid program is. The Medicaid program is a cooperative federal and state health and care coverage program. This means we must be in compliance with not only local, but federal regulations in order to draw down our federal share. So how do we stay in compliance? Well, program integrity, of course. So what is program integrity? As the Medicaid Program Integrity Division, our goal is to prevent and eliminate fraud, waste, and abuse in the Medicaid program. We do not do it only to protect the program, but also for our eligible beneficiaries who are entitled to receive medical coverage and services. So how can we, before I can talk about our program integrity activities, I would need to talk about the elephant in the room. The favorite phrase in the Program Integrity Division and mentioned repeatedly during the first day of the summit: fraud, waste, and abuse. So what is fraud, waste, and abuse? Medicaid fraud, waste, and abuse involves deliberate deception, unnecessary costs due to inefficiencies, and improper practices that drain taxpayer-funded health care resources. Examples could include billing for services not rendered, upcoding, kickbacks, or submitting false eligibility data, or dual enrollment in multiple state Medicaid agency programs. Although only fraud and abuse are defined in Medicaid regulations, Medicaid takes waste very seriously due to its lasting negative effects it can have on our limited medical and financial resources. So I really want to see if everyone's awake. Pop quiz. What do you think are the common types of fraud and abuse? I did actually mention some of them. I'll give you maybe 30 seconds because time is ticking. Okay, I heard some of them. So basically, these are some of the types of fraud and abuse that's commonly found in Medicaid. I won't go down the list because there's quite a lot of it, and we have very limited time. So, program integrity activities. The Program Integrity Division primary functions are listed above. Program Integrity oversees and manages provider enrollment. Program Integrity conducts audits and investigations in partnership with local and federal agencies. Program Integrity also supports outreach and education to our Medicaid stakeholders in partnership with our Medicaid Public Relations team. So why do we handle provider enrollment? Well, the best way to combat fraud, waste, and abuse in the Medicaid program is to stop it at the onset. Everyone is affected when fraud, waste, and abuse is not addressed. It saves taxpayer dollars and also victims from harm, whether it be financial or health. During the provider enrollment period, Program Integrity has the opportunity to educate and work with providers to ensure they stay in compliance with our Medicaid policies and procedures, along with federal and local regulations. I kind of mentioned it before, but before we discuss on these requirements, I just want to go over the difference between Medicare and Medicaid, because I know not all of our providers are Medicare providers and vice versa, as well as our beneficiaries who are dual eligible, meaning they have both Medicare and Medicaid, or just Medicaid-only beneficiaries. So basically, Medicaid and Medicare are separate programs. Medicare is run by the Centers for Medicare and Medicaid Services, and Medicaid, like I said before, is a federal and territorial cooperative healthcare program. Medicaid and Medicare also have different requirements for enrollment. And finally, being a Medicare provider does not guarantee your enrollment in Medicaid. If you are a Medicare provider, you still need to submit a provider application to Medicaid. So, provider enrollment. To be in compliance with federal regulations, Medicaid requires provider agreement and disclosures along with site visit for new or revalidated providers. Additional documentation and information may also be required by our agency in order to complete your provider application. Listed on the slide are some of the enrollment activities conducted by our division and the statutory authority that requires our agency to conduct these activities. So just want to see if everyone's awake. You have those little true and false. So true and false. Medicare and Medicaid are separate. You do not need to submit a provider application if you are already a Medicare provider. Okay, great. So people are listening. So yes. So Medicaid and Medicare are separate programs. Therefore, you must submit a provider application to Medicaid. So current program integrity activities. Common functions of the program integrity include prevention, investigation, education, audit, and recovery of improper payments from providers or beneficiaries. Our Program Integrity Division, in collaboration with fellow Medicaid Division counterparts, our grantor, Centers for Medicare and Medicaid Services, and the CMS Unified Program Integrity Contractor, or we like to call them UPIC, use a number of tools to identify and address fraud and abuse in the Medicaid program. These specific methods can include data mining to identify possible fraud and abuse for further examination, provider and beneficiary audits to determine compliance with federal and territorial statutes and regulations or to identify fraud and abuse, investigations and audits of suspected fraud and abuse, and also enforcement actions against those who have already committed fraud and abuse, which we would actually refer to federal and local law enforcement for further review and action. Many oversight activities focus on identifying and recovering improper payments made to providers and beneficiaries, such payments that should have not been made or were made in an incorrect amount. When an improper payment is identified, the American Samoa Medicaid State Agency must return the federal share to the Centers for Medicare and Medicaid Services, while the local match is returned to our local subsidy account. So, what could trigger an audit? Data discrepancies found in financial, eligibility, and enrollment data submitted by providers or beneficiaries. Complaints from the public or providers. Examples complaints could be related to the quality of the services they received or just services not being rendered to them. And finally, known and emerging fraud and abuse schemes and trends. For example, the Program Integrity Division regularly receives updates on emerging fraud and abuse schemes and trends from CMS, private health insurance partners, and other state Medicaid agencies. Results in these schemes and trends could prevent bad actors from enrolling in other Medicaid programs or could lead to nationwide provider enrollment moratoria where certain provider types are not being enrolled for a certain period of time due to the high prevalence of fraud and abuse. So, if you are audited, what would make a successful audit? Documentation. Providers must retain documentation to support services and claims and beneficiary data for a minimum of 7 years. Being prepared for interviews and site visits. When Program Integrity contacts you for an interview or site visit to verify claims and beneficiary data received, please provide the appropriate staff who can answer the important questions and queries related to the submitted documentation received by our division. And finally, respecting deadlines. Very self-explanatory. So please provide required documentations in a timely manner. If you need more time, tell us and don't assume we will allow it. Certain processes within our auditing and investigative process have specific timelines that are mandated by law. So my last true and false, just to see if I didn't bore everyone. The Program Integrity Division can receive complaints or tips from the public. The answer is true. So you can. So you can report any fraud, waste, and abuse you see in the public or at the providers. Please provide as much information as you can regarding the tip or report. The slide above shows some examples of what you can provide to our office that can help our agency when developing our audit or investigation. And if you would like to submit your report, you can email or contact our office directly or mail the complaint to our office. Some of the information for contacting us is listed on the slide. And please take note that pursuant to 42 section 455.14 requires all complaints and tips, leads, and suspicious claims, whether from providers through our data mining efforts or from the general public, must be investigated just to see if there's any credible allegations of fraud and abuse in the program. So we do take any tip we receive seriously. So finally, I'm going to end with our outreach and education. So outreach and education is very important for the program integrity efforts and activities. Educating the public and our providers on current program requirements, eligibility, and program integrity processes could prevent improper payments before they occur, and overall prevent fraud, waste, and abuse in the Medicaid program. We can share this information through our annual summit, which we are having right now, and also through local conferences and meetings held by our sister agencies, providers, and nonprofits. If I get the green light from my director, I'm more than willing to come and present anything for you guys. And as a part of our continued efforts in creating more impact with our program integrity outreach efforts and emphasizing on the prevention theme with this summit, my division will be hosting its first provider workshop this fiscal year. We will be sharing important provider enrollment requires and documentation that will be required in the new fiscal year. More information on this workshop will be shared with our current and prospective providers. And finally, as needed, provider newsletters on new changes in provider enrollment and program integrity requirements will be shared on our Medicaid website. So if you have any questions, now's the time to ask. Yay. Yeah.
We have one question here.
Yeah, good afternoon.
Hello.
Because I am a licensed speaking, I'm a certified diabetes educator. And a lot of these patients are my clients. And the reason why I'm asking because with Medicaid, with the topic that you mentioned on abuse and fraud and so forth, there are some tendency for providers to order unnecessary tests that contribute to a higher bill. So, so that indicates the need for a comprehensive assessment of each patient when he or she comes to you, to your facility, and then to identify what is the diagnosis there is, and then to tailor your tests to further diagnose that condition that you have identified. So that's the thing I just wanted to share, because this is a very common thing to occur. Thank you.
Okay, so just so I understand, you did mention that there are some unnecessary tests and that are being billed or being done to the patient. Well, technically, that's a type of Medicaid abuse and fraud. So if these services are not medically necessary, Medicaid is not supposed to be reimbursing for those services. Well, I would need more information. I cannot say what's that scenario you're providing to me, but that is a very serious allegation that if it were to be received from the public or from a provider, I would have to investigate and audit that, whether it's through the Medicaid program integrity or with our partners in the federal agency with UPIC. So feel free to, we can talk later.
Do we have any other questions? Okay, I believe that is it for program integrity. Thank you so much, Matilda Kvzk. And we're going to dive right into our next presentation as we are short of time. And this is a presentation on home and community-based services, HCBS, another big part of the Medicaid program. And to present is the data analyst and HCBS specialist, Miss Beverly Liu.
O te taritonu a vela le fala, ai awa le pole, o le whaatoro le anto e susu ia i o leo forsanga mo le nei aso, o le a whaapupu lava. Whaatalofa mwhawhelo i atu, i le paia ma le mamalu o a whanga poto mai i le nei aso. I ona tūlanga ngā luenga, o te tūla i lava mo le uawa tele ma le whaaloalo, e soli tū ina ailo o tō mamalu. Ia, o le nā whaiwa te atu se matu palapala i le whonga le nei aso. Ia, ma o le a whangatonu loa le ifio maina, ia e ala i tūla i ona manu fo i le tatou taimi. Malo lava lon sat. Greetings, I'm Beverly Liu Tufuli, and I serve the Medicaid State Agency and programs as the home and community-based specialist, as well as the data analyst focusing on beneficiary experience and support. I serve in a program-level role under the leadership of Director Louisa Kwaya, while also working closely with State Director Tafai Mamau Tupola through the Money Follows the Program, Money Follows the Person program. Next slide, please. I serve as a liaison helping bridge these efforts, aligning Medicaid policy with practice, Money Follows the Person strategies, and ensuring that our work moves forward with readiness, purpose, and the real needs of our beneficiaries, so that our long-term care grows in a coordinated and cultural grounded way. Our mission is advancing services through care, data and quality assurance, in strengthening beneficiaries' experience, improving care coordination, building readiness for long-term home and community-based services, and supporting leadership. Medicaid provides the policy authority, the state plan structure, and the long-term sustainability needed for HCBS. Money Follows the Person provides the federal grant support, technical assistance, and cross-agency collaboration needed to identify service gaps, pilot solutions, and prepare for HCBS options. Together, these two programs share the same goal: to build a sustainable, culturally grounded system of care that supports our people in their homes and communities. Telo nei tangata ua fesili po ole alia pro kalame, ai po ai fo I benefiti ai po lea fo ilo na winga. The simple truth about home and community-based services, it is a variety of medical and long-term care supports designed to help our elders and individuals with disabilities to live independently in their own homes or communities, rather than in institutional settings like nursing homes and hospitals. O le nei benefiti fo o loo tau a mata I mōna i o tātou ta mā, ma tina mātutua, o loo tau sia I maota malawa, whaapea na i o tātou tangata e iai mana o ngā whaapitoa, na I lo tutono whaalapotopotonga whaapitoa, e pei o le tausi soifua, po maota ngase ngase. This is not just a program or a benefit. It is a vision for dignity, independence, and culturally grounded long-term care. Next slide, please. American Samoa is unique. We operate under a special federal authority called the 1902 J Authority, or the Congressional General Waiver, the same one highlighted on yesterday's presentation by our deputy. This authority shapes our Medicaid program functions and give us a structure that is different from the stateside Medicaid agencies. I'm sure we all know that. This flexibility also allows our territory to expand personal care services through a state plan amendment, and this expansion supports adult daycare, adult health care, long-term care support settings, assistance with activities of daily living, and instrumental activities of daily living. This represents our first major step toward a broader HCBS system built through shared effort, shared vision, and shared commitment. We are working on the quick wins as we continue to lay the groundwork for HCBS, building HCBS step by step and design services that fit our island culture and needs. But this flexibility also means something very important. We must build carefully, sustainably, and with readiness, because our system is designed differently than state-based Medicaid programs, as mentioned earlier. With that said, HCBS require deliberate work, a strong provider network, which we don't have yet, a quality assurance system, a person-centered planning, EVV or electronic visit verification and documentation system, administrative capacity, financial sustainability, and most importantly, a clear vision and an action plan. Ia marito ang ay tatalong fatu tua ilia tua e ilia so tali mai ai ile tato mata tato benefiti fo ilia. We are building towards that level of readiness, step by step, with intention and purpose. Our job today is not to promise a waiver. Our job today is to prepare for one. Our responsibility is to ensure that when the time comes, American Samoa is truly ready. That means CMS will allow us for this 1915C waiver. Our vision and what we are working towards includes scoping out possibilities for long-term care, identify service gaps across agencies, understand financial limitations, and lay the groundwork for future HCBS authorities. This is not about rushing. This is about building wisely and building smart. It takes patience, perseverance, teamwork, and commitment. So what are we doing now? The groundwork. Next slide, please. Everything we are doing today is laying the foundation for tomorrow. O mea umalava o matu ta apena ai le aso, o lo fata oto se fa o lo fata oto ai se fa vai mo taiao, e te le lava le ngaluenga, o lo tau amata, ai o lo ngalue fa atasi vai nga tu ma oti o nei prokalame, ia fausia ma ia mausali le fa vai e tusa maalo le tu la fono ma ia inga. These are not small steps, but these are building blocks for the future of HCBS system. And why does readiness matters? Because it protects our beneficiaries, you, our Medicaid program, our federal funding, and our long-term sustainability. Our approach is simple. Build deliberately, build wisely, and build sustainably. This is why readiness matters. And this is why you matter. And this is why we are doing this work. Home is where the heart is. And while a house is just a structure, being cared for in the comfort of your own home is why we are building home and community-based services. Independence is not just a goal, it is dignity for every person, and they deserve that dignity. This is for you because you are the heart of this program. Next slide, please. Now I transition into my second role. All right, let me put on my other hat. The data analyst for beneficiary experience, focusing on beneficiary experience and support, or the DAPES initiative. The DAPES initiative was created by our director, with one purpose: to hear directly from our patients about their experience throughout the entire process. Their voices, your voices, matters, and it guides us, strengthens us, and helps us improve the way we serve. In all of our 4 current benefits, off-island referral, vision, durable medical equipment, and orthodontics, your voice matters in every one of them. Through wellness checks, follow-ups, and experience surveys, we ensure that beneficiaries feel heard, supported, and respected. This work strengthens quality assurance, service coordination, beneficiary voice, program integrity, and trust in our system. As we continue building a healthier, more resilient American Samoa through prevention, we must never lose sight of the people at the heart of this work, our beneficiaries. Their voices remind us why we do what we do. Behind every service we provide is a person whose life has been touched. With care, support, many have found new strength to care for their health and their future. Here is one beneficiary story that shows how care and support can restore strength, dignity, and hope. This is Amaziah's story. Next slide, please. Yeah, some audio, please.
Talofa everyone, it's Mama Amaziah here. Amaziah is one of the patients that was medevac from American Samoa to here in New Zealand, and we'd like to share our journey with you today. With the help of our Medicaid team, our journey has been going so smooth and easy with everything from surgeries, treatments, places to stay, food, everything that we needed. Our Medicaid team helped us and covered everything, majority of everything for us. And we would like to say thank you, Medicaid team of American Samoa, for coming through and for all that you do for us. We appreciate you. Thank you. You want to say something?
Hello, my name is Alcina Amsayapang. I just want to say thank you for supporting my journey.
Okay, thank you. Alofatu. Bye.
Thank you, Maya. At the end of the day, whether it's home and community-based services or data analysts for beneficiary experience and support, the purpose is the same: to serve you, our beneficiaries, with dignity, quality, and care. Prevention is not just a policy, it is a shared commitment. Together, we are building a healthier, more resilient American Samoa, one voice, one family, one step at a time. Peo se tasio moanga ngana, e so o le fau I le fau. One vine supports another, and unity is our strength. And before we close, I want us to try something together. Would you kindly get up off your seats, please? You can just keep at your seats without movement. Okay, please stand exactly where you're at, and with no movement, I want you to stretch out your arms as far as you can. Stretch out your arms. Okay. Now try to reach the people at the next table. Just try without movement. Just try. Okay. This is what it looks like if we work separately. We're close, but not connected. We are trying, but we can't quite reach each other yet. All right? Now take one step forward, please. All right, take one more step forward. Now try to reach again. Try to reach the next person next to you or to the next table. Have we connected to anyone yet? Have we connected? Okay, thank you. This is how it looks like. Building teamwork, it takes perseverance, patience, and us working together as one. One step at a time, we move closer. One step at a time, we align. And when we finally reach each other, that's when we build a reliable and solid infrastructure strong enough to carry us through this journey all the way home. Whaftai mo lo'o wanoa, please take your seats while you're already seated. Mo ni tatou fesili o nawa uti le taimi, o le a whaatali se mai a le folasanga a le sui whaatonu o le whaatonu sili, le tamaitai a tawhai mamau for money follows the person. Whaftai.
Ladies and gentlemen, that was Beverly Liu Tufuli. And bringing on to the stage, we have State Director Tafai Matua Tupuola presenting on Pacific Center for Human Security and Money Follows the Person.
Thank you so much. I greatly appreciate the prelude, it's easy for me to flow right into this presentation. So money follows the person. And how we're tying it all together with the Medicaid Summit and how it connects. Next slide, please. So what are the goals of Money Follows the Person? It increases the use of home and community-based services. That's exactly what Beverly had just covered. Plain language, it's just accessing community-based services. 2, eliminate barriers or mechanism. It's just another additional way to provide supplemental services. Work with Medicaid on state plan amendment and waivers. 3rd, increase the ability of state Medicaid program. It's a way of kind of getting more and more eligible individuals to participate in Money Follows the Person. And 4, ensure that procedures are in place. And this has a lot to do with an approved operational protocol and internal procedures. So there was some discussion about long-term support services and support. Just real quickly, there's 2 models. There's one that talks about the facility. So think of it like LBJ. And then there's home community-based services, which is what was covered from Beverly. Next slide. So how do you connect LTSS and Money Follows the Person? Money Follow the Person really covers the transition piece. Getting people who are institutionalized in LBJ to get them to move and return home. Next slide. So Money Follows the Person covers activities that are not covered under Medicaid, which is recognized as supplemental services. It can cover home modification, rental up to 6 months. It can also cover utilities, food security of up to 30 days, vehicle modification, and transportation services. There are more, but this is just the gist of it. Next slide. So target population, you have to be one of the target population that we are approved to focus the activity on. And so it's 65 years and over, a physical disability, intellectual or developmental disability. It could be someone with autism, someone with Down syndrome. 4 is mental health and substance use disorder. And then 5, HIV, AIDS, and others. However, because of the health data that we are able to justify, we were only able to justify to target 65 years and over and physical disability. We could not find enough data to pull in other target population. Next slide. So, in order to be eligible, you have to be one of the target population that we are focusing, which is 65 years and over and physical disability. You must be in an institutional setting, which is LBJ, for up to 60 days or longer, qualify for Medicaid, and financially feasible, that when the program ends for you, that you're still able to financially cover yourself, whether it's paying monthly rent or transportation or the utilities. And you must have a service plan that's already provided to you from the hospital. Next slide. So money follows the person is not a permanent activity. If you qualify, it's only going to fund your activity for 365 days. 366 if it's a leap year. So this is just an example of the first 60 days. We go through this financial feasibility. We wait for your service plan. And then we start this transition. Look for you an apartment if you don't own a home. But if you do own a home, we work with the third party to handle the home modification, and your home must be assessed from an occupational therapist, which we don't have here on island. That OT works with the contractor on the home modification, and then we'll assess to see if it met everything that was recommended in this assessment. And then if you notice, after 365 days or 366, it then transitioned into Medicaid. But HCBS is there, and so it covers during that whole transition phase. The one thing I want to make sure is that, do you have to live here in Tutuila in order to qualify for home modification? No, if you live in Manua and that's where you want to return home to, we cover the entire transportation, moving you back home to Manua. Next slide. So how are we achieving the goals? So I just wanted to give everyone an update where we're at so far. Next slide. So going right back to our goals, we realized that we could not achieve increasing the HCBS without eliminating the barriers. So what are all these barriers? Well, this is the part where we realized it's a bigger territory-wide problem we needed to sort of come together to talk about. Next slide. So if you were to look at this, I'm now doing the layers of money follows the person. You have supplemental and HCBS. If you look at what specific activities happen under those spaces, it would require home modification, rental, food. So this ties in perfectly into what Matilda shared earlier about making sure there's no double payment. Hence why we have to work with an agency like DBAS, because if you are a recipient of the Mauta Home Loan Program, for example, how do we know that we're not being double billed from what you're receiving from one entity and you're receiving the same thing from another agency? So this requires a lot of detailed work. Next slide. So then we also realized, thinking about the infrastructure we need to build in the community, is that we have outdated policies and regulations. That's a fact. Everything is so outdated. And so keeping the supplemental services and HCBS in place, we realized we have no housing code. So let's think about the housing. If you have mom or dad that uses a wheelchair in your home or have limited mobility and your home is not accessible, the chances of them falling or slipping or tripping because of their disability, they will end up back in the institution. So this was a way of rethinking what our living environment looks like. So then we have to talk about housing code, ADA, that is not adopted here yet in its entirety in American Samoa. And then what are the limitation of home modification? MFP, if it's an approved, it covers everything within the home to the driveway, but it must be a recommended assessment from an OT. And then if you look at HCBS, exactly what Beverly was talking about, it's to start the readiness. We're starting the conversation. Next slide. So the governor had signed an executive order, HCBS commission, and this is a way, now we're bringing stakeholders together to talk about outdated policies, to talk about regulations, to make sure safeguard measures are in place. So this is an opportunity to address system-level conversation, getting a collective input from all key stakeholders. Next slide. And then there's the payment. So the supplemental services, if it's approved, it's 100% covered by money follows the person. From under HCBS, once that is approved, it goes through the thorough process under Medicaid. If they're still within that 365 days, money follows the person will cover up to 90% of that cost. However, we still need that 10% match. Next slide. And then capacity building. So even while we're addressing this, we don't have personnel people that would meet the criteria to do a lot of the work. Like I said earlier, we don't have an OT. We need people to do more person-centered training. We've invested in the billing and coding certification. We paid for about 11, and it was just a one-time thing to try and get enough people to code, because CMS likes to look at the cost of care when they pull the code. Next slide, thank you. So the current capacity building activities, right now we've already procured a community health worker curriculum. We are making that available online, crossing fingers, it's ready to go in August. And the community health worker curriculum will establish a foundation, and then a caregiver will be a special track. Case management can be a special track. Nutrition can be a special track. Same as education, which some would use as teacher aid. And I just covered a little bit about the billing coding. So out of the 11, 3 passed their certification for coding, and then we have 1 person from Medicaid that is certified under the billing. I also want to recognize one of my staff just passed the coding certification as well. Next slide. So this is one of those things where Medicaid was talking about being creative, and because HCBS is not in place, we can still find creative ways to do training. And so we were able to partner with EPIC, with Katie McCutcheon, who is currently doing caregiver services and is now opening up adult daycare. So while we wait for HCBS to navigate that, we were able to justify how can we train family caregivers in the home. What was happening is that we were doing caregiver training, we were expecting them to come to the classroom. That meant they had to leave the family member at home unattended for the full 8 hours, X amount of weeks. But the training needs to be in the home so they would not leave the family member. So we are looking at training 50 family members, 50 households, and because we cannot do assessment, we are targeting bed-confined individuals with their caregivers to get trained. And with training supplies, because we know medical supplies are very limited. Again, this is not permanent, this is just training. And to make sure that the skills and the knowledge is applied in the home, we recommended that a post follow-up is done to go back and visit the family. Now, last minute, we then realized we can't do family caregiver training, and majority of them have health issues. So now we're exploring contracting an agency, a consultant, to do the nutrition training together with the caregiver training. So they're working together to train the family members in the home. This is just fresh off the press. We just rolled out some of the paperwork last week, and we're still trying to work and trying to solidify a lot of pieces. The other thing I wanted to say that I forgot to add on the capacity building, there was a lot of discussion about health data. We are also exploring on investing in a territory health data dashboard. We are working with the new CIO director, Ray Tulafono, on trying to procure that and where would be the best place to house the health data dashboard that we can all be able to access and answer a lot of our questions. Next slide. And that's it. Thank you so much.
Thank you so much, State Director for MFP, Tafai Mao Tupuola, for that lovely presentation, a follow-up. In addition to HCBS Specialist Beverly Liu Tufuli's presentation. Now, we do have a little bit of time for our questions regarding home care-based programs. Pa'i?
Testing. I want to share this, not only just a question, but as a mother. It's a bit lengthy, so please bear with me. When we lived in Utah, my son was diagnosed, who is diagnosed with autism spectrum disorder, received the care he needed. His therapies, his medical support, everything was covered through Medicaid. I saw him grow, improve, and have a real chance. Now, here in American Samoa, the reality feels very different. And as a parent, that's hard to accept because our children deserve the same chance no matter where they live. So I want to ask, where is the disconnect? And since we raised this concern last year's summit, what progress has actually been made to close that gap? I also want to ask about data because I remember it being said last year that we need it. This leads to my question, have we collected any meaningful data on autism in our community? And how is it being used to help families like mine? Also, I wanted to ask Tafafa Mulmole, why is MFP targeting the age 65 years or older? Because you mentioned autism. And moving forward, what real steps are we taking to build better support so that families don't feel like they have to leave home just to get care? I say this with respect, but also with urgency, because our children are growing every day and they cannot wait. On that note, my sisters and I, a small organization, not yet official yet, soon, called Melofa, Fearfully and Wonderfully Made Spectrum, conducted a short online survey, so please help us by going on our Facebook page to fill that out. We did it because we want to understand developmental concerns and access to services for children in our community. We put it together after seeing so many families share their frustrations publicly, and we wanted to turn those experiences into something concrete we could bring into spaces like this. Even with just 20 responses, the pattern is clear. Most families are noticing developmental concerns, but the biggest barrier is access. Many have traveled off island for diagnosis and services, while others want to, but simply can't afford it. What are some concrete steps we can take now to begin building that data? More time is passing and we're still in the same place. We still have no data. When I walked in, I immediately started looking around to see any rep from SPED, my favorite department, but unfortunately they aren't here. So I would love to see them next year, Lord willing, Director Kwaya. My son, Alapati, is doing well at SPICC, but he is starting to fall behind in school, and so we are fortunate that we have the option to relocate him to Family for Support. And we recognize what a blessing that is. We will continue to advocate because we have lived this experience and understand how difficult it is. But what about families who don't have that option? What's next? Well, April is coming up, which is Autism Awareness Month. We have our walk on April 4, just like last year, featuring Zumba with Erica, so please come out to support. Thank you.
I can go ahead and answer the question because it's a very legitimate question about autism. What was happening was that when we reached out to certain agencies to get data, even on Down syndrome, autism, there is a large climb. However, the numbers were so inconsistent because some agencies said, oh, we only cover 0 to 3, and then one would say 3 to 21, and the other one said, oh, we cover 0 to 21, but the data was very inconsistent. And then we couldn't find data in adulthood. There seems to be this mindset that disability only exists in special education, that when they're adults, they're healed. You don't capture their data. And so this goes back again, where people are so protective with data, and I get it, because when people show data, judgment kicks in. We say, well, why didn't you do this? And why is your data? The reality is that now how can we take that data and identify this as a need or for improvement? The issue with the autism data is that no one, I shouldn't say no one, agencies are not elevating that data for us to use it and capture it. So if I was to take the data that I had last year, all I got was 40, compared to the 3,000 something of 65 years and over, and I got that data from the census. Then I look at the physical disability because I can pull the data of amputation, the older adults, you know, so that number is like all in the 1,000, and then I get 40. And so it's a matter of getting the agencies to share more of that data, so in that way we can say there's a need. I did have a conversation with Norma Smith from the DD Council. So there is a possibility of seeing, can we elevate that if there was additional mechanism to elevate the DD population. But I hear you. Thank you.
So to address your comment about what has Medicaid done, so because of questions like this, we're currently working on amending our state plan to add behavioral health services, primarily ABA services that would benefit your child. It's still in the process, it's taking time, but we will announce it to the public once it has been approved. It's going through the process with CMS, and that does take time. On the other hand, although we have these services covered, it's a matter of providers available in the territory. It'll take something that from other agencies or other nonprofit or community efforts to help bring down these specialists, because then we could pay them when they're here. Because unfortunately, we cannot send them off island because we know how long it takes to get the diagnosis. I know personally, my nephew was diagnosed with autism, and it took a very long time to get his diagnosis. So we have to be realistic with our local funding limitations. So that is one step we're trying, because we do know there is a local clinical psychologist who could help with some of these services, and we do have local private behavioral health clinics that is already providing these services. It's one step, but we're slowly building up to providing the services our community needs.
Testing. Thank you for coming and for your questions. Saving the best for last, I see. You know, we do have the chairman of SPED here with us, Motusanua, sitting right here, and he has been actively engaging in trying to get access for your children. He has inquired of Medicaid as to what eligibility or the eligibility of Medicaid coverage for students in the schools, and we are having those conversations now. On our end, it's more of a policy issue than anything, but to Matilda's point, we do need the providers, and that's why we don't have the infrastructure. And so with Katie and her team building that I think St. Catherine's up here, and then I do hear that there are other providers trying to come to the table. And I also know that Lorena Seo is working with off-island providers to get them here. And I hate that it's taken us a year to respond to you, but this is how things work here, and I hate it. It's so slow, you know, and we want things to happen quickly, but because there's so much so many parts in this, it does take a little while, but we are working on it, and we want your children, we want all of our children to get the care that they need, and we shouldn't have to have them go off island for that care, and that's what we're talking about here.
And I just wanted to add on to what has been said, because this case in particular, when you noticed something was different, special about your son, you had reached out to me in particular, because I know of Charisma from the community, mutual friends, and it was so heartbreaking to give you the news of not being able to cover for your son in terms of off-island referral, because it was just the way it was. Our state plan had not been amended yet to include autism. So when you did ask this question last year, and then following it up this year, I was actually looking out yesterday to see if you were going to join, and when you did come in today, because it's not a major step, but just this one step that our program integrity division head and her analyst, Agnes, are working on this spa. I was like, yes, we have an update for Charisma if she does show up today. It's not a major step, and as we learned yesterday in how we do these state plan amendments, for all the providers that we've onboarded in the last few years, it takes a while. But as HCBS State Director, Specialist, and also MFP State Director have mentioned, we're laying down the groundwork, and hopefully next year's summit will have even better news for our community, because it is a growing problem, and all our children deserve the very best and quality care from us. So I just wanted to add that in there. Are there any other questions aside from Charisma? Okay, I know it's been a very long day. We anticipated the second day of the summit to be even shorter than the first day yesterday, but because of these meaningful conversations that we've had, from the great presentations of finance to the panelists, and even for HCBS and program integrity, we just cannot leave here with our questions unanswered. Now, I do apologize, there were a few questions that we didn't get to, but please visit our office. We welcome all these critiques, we welcome the suggestions, recommendations, and we are an open office. Yeah, we can definitely sit down, bring it to the table, and just start collaborating more and more, that by next year's summit, it'll be an even bigger and better summit for all of us. So without further ado, Director, did you want to say some final words before we close off?
I just wanted to thank you all for coming today. It was a wonderful 2 days of collaboration, and just going back to our theme, strengthening a health resilient American Samoa through prevention. It's a really hard thing to do, but we can do it together. I also wanted to give a shout out and kudos to my team. I'm extremely proud of them. They get me emotional sometimes. But everyone in the Medicaid office, we work hard and we prepare for these types of events. And I'm appreciative of their sacrifice, particularly our committee of 2 sitting right behind me. I want them to take a bow. Manino Reed. And where's Jeremiah? Jeremiah, come out here, don't be shy. And Jeremiah, this is the team, okay? So if you've enjoyed yourself today, if the experience was phenomenal, it's because these 2 right here. And, I want you to join in with me. He's gonna hate me for doing this, but Jeremiah is celebrating his birthday. So if we can sing happy birthday, Deputy, can you lead us in the happy birthday for Jeremiah? Fale.
Happy birthday to you. Happy birthday to you. Happy birthday, dear Maya. Happy birthday to you. Manu yellow asafana. Manu yellow asafana. Manu yellow asafana. Maya. Manu yellow asafana.
Hip hip.
Hey.
Hip hip.
Hey.
Thank you, Maya. So sorry, you can talk to me later after this. But I just want you to know how much I care for my team members, and we care so much for all of you. And this is why we do what we do today. Thank you so much for your participation. I really hope that you will take what you've learned and experienced out into the public, out into your communities, into your villages, and keep the conversation going. Don't wait for Medicaid to start it. You can keep it going, and we can continue the work together. Thank you so much, Papatai Lava.
Now, before we leave, the QR code for our summit feedback. Last year we had a whole lot of feedback that we tried to incorporate into this year's summit. So if you have any feedback for us, please go ahead and submit. We welcome all feedbacks. Yeah, without further ado, I think that is the end of our summit. Thank you so much for coming out. Thank you to all our partners, our counterparts, and even to our sponsors. Thank you to the media team. And if you make your way out, everybody is getting a Medicaid flask. Paftai soifua maiamanuia.